Good afternoon. Welcome to the third annual Advancing Mental Health Policy Forum. My name is Kabir Nath, and I'm the president and CEO of Otsuka America Pharmaceutical, Inc., the US affiliate of a global Japanese pharmaceutical company with a strong legacy in mental health and a commitment to developing innovative solutions for people living with mental illness. On behalf of everyone at Otsuka, we are pleased to be the host sponsor of today's important event. Many of us here today have a deep personal connection to mental health, whether through a loved one, a friend, or a colleague. Many of us know someone who has been affected by schizophrenia, depression, anxiety disorder, bipolar disorder, or another mental illness. Most of us know also that mental health policy is one of the most challenging areas of public health policy. So I thank you for coming together today from across different sectors and disciplines to discuss some of these challenging issues. Fittingly, the theme for this annual event is Better Together. And while I wish we could all be physically together in one room as in years past, I'm incredibly excited and appreciative to share this virtual stage with key policymakers, thought leaders, and experts from across the mental health community. Together, we will explore innovations and policy solutions to strengthen access to care for people living with serious mental illness. Despite the physical distance that separates us today, I am indeed confident that we are united by collective expertise, innovative ideas, and an unwavering resolve to see true change in the way mental illness is managed in America. We are truly better together. I'm also pleased to let you know that both of the sessions today, technology-enabled access to care and mental health crisis response, will be live with interactive discussions. Attendees will have the opportunity to ask questions during the Q&A at the end of each session. And all remarks and sessions will be recorded and will be available for viewing after the event in the virtual attendee hub. Let me start with a few reflections on 2020. While 2020 is thankfully behind us, the world continues to grapple with the unprecedented challenges brought on by the COVID-19 pandemic. In the US, we have endured a staggering and shocking cost with more than 500,000 lives lost and a healthcare system buckling in many places under the strain of providing care. Thanks to determined collaboration by policymakers, regulators, the pharmaceutical industry, healthcare professionals, payers, and a host of others, about 1/3 of Americans have been fully vaccinated to date. But unfortunately, the mental health challenges of the pandemic endure. Millions of Americans, including many healthcare professionals on the front line of battling the pandemic, continue to grapple with the mental health challenges arising from it. In January of this year, the arrival of a new administration brought a renewed optimism and an opportunity to focus on access to mental health care. The skyrocketing demand for mental health care has spurred novel delivery mechanisms, including technological innovation and the widespread adoption of telehealth technology. Our speakers today will discuss the groundbreaking emergence of mental health technology and policy innovation, the opportunities on the horizon to expand access, and the ongoing challenges that must be addressed to ensure equity for all who need care. Before we get into today's discussion, I want to highlight several key areas that will influence and inform the discussion. Let me start with the RAND report. Earlier this year, RAND Healthcare, a division of the prestigious RAND Corporation, a nonprofit, nonpartisan research organization, published its report with findings on how to transform the US mental health system. This research, sponsored by Otsuka, should galvanize our nation around the need to address the mental health pandemic that has been exacerbated by COVID-19. RAND researchers examine the mental health system broadly, including not only the institutions and resources that support the delivery of mental health services, but also the social determinants of health that impact the lives of those in need. As you all know, these include, among others, access to housing, homelessness, incarceration, unemployment, and education. Based on their insights, RAND articulated specific recommendations aimed at improving the US healthcare system in 3 areas. The first, promote pathways to care. This includes promoting comprehensive mental health education in K-12 settings, integrating behavioral health expertise into general healthcare settings, linking homeless individuals with mental illness to supportive housing, and developing a mental health diversion strategy centered on community behavioral health, which can help to prevent our jails and prisons being the primary place of care for so many living with mental illness. The second area is around improving access to care. Recommendations include strengthening mental health parity regulation and enforcement, reimbursing evidence-based behavioral health treatments at their true cost, establishing an evidence-based mental health crisis response system, and expanding access to digital and telehealth services for mental health. And the third area then, to establish an evidence-based continuum of care. To enhance quality of care within the system, RAND recommends that decision makers consider defining and institutionalizing a continuum of care in states and communities, launching a national care coordination initiative, and forming a learning collaborative for Medicaid behavioral health financing. At Otsuka, we are continually working to bring together a coalition of people to discuss the pressing issues that impact outcomes for patients with serious mental illness and advance the actions needed to transform our healthcare system into one that responds first and foremost to their needs. We are optimistic that there is a willingness to implement the changes that will transform the system into a patient-centric one which, like Otsuka, respects the value of every mind. Let me talk a little around patient centricity and digital innovation. Otsuka has long been an early adopter of advanced digital solutions to make technology more accessible to patients, generate better evidence to inform treatment plans, ensure patient safety and data integrity, and optimize trials to meet the needs of patients wherever they may be in their wellness journeys. Over the last more than 5 years, we've leveraged tools such as e-consent, e-source, e-scanning clinical supplies, and so on, to provide real-time insight to our clinical trial activities. We collaborate with companies such as Barrett to drive siteless clinical trials. In February, we announced a landmark, fully remote clinical trial to investigate the effectiveness of digital therapeutics in reducing depressive symptoms in adults diagnosed with major depressive disorder who are on antidepressant monotherapy. We believe it's critical to explore innovative methods such as siteless, fully remote trials to increase the number and diversity of study populations by making it easier for a much wider range of participants to enroll in them and to contribute their health data. Keeping patient centricity at the core of health technology, whether it be development or deployment, ensures that we as an industry are always asking the right questions. By challenging health technology with patient centricity at every turn, we can stay on course to deliver valuable and impactful solutions. I'd like to talk now about diversity, equity, and inclusion. Events over the past year have also put the spotlight on these issues of diversity, equity, and inclusion in America. In healthcare, we need to urgently establish partnerships to include underserved patient populations in the clinical development process. We must also ensure that these communities have access to these drugs and devices when they are brought to market. As we know, this is a particular issue in the treatment of mental illness. Lack of access will only further drive health disparities. As researchers and developers of these therapies, we must address the systemic inequities within our healthcare system that limit access after product commercialization. We must simplify the journey for both patients and providers, leveraging patient support services, making it easier for them to learn about our products and services and enroll in trials as appropriate. Digital innovation will in time be a key factor in this, while still incorporating the human touch throughout the journey to provide personalized support when and where it is needed. But we must also recognize that there are wide disparities in the access to technology fundamentals, for instance, broadband and smartphones, and we must also advocate for solving these. Within the broader healthcare system, there is underrepresentation of cultural, gender, and ethnic diversity during training and in leadership. To serve the needs of a diverse population, it's imperative that the healthcare system take measures to improve cultural competence as well as racial and ethnic diversity. Otsuka is a corporate sponsor of the Journey to Better Health Consortium, led by the Center for Information and Study on Clinical Research Participation, or CISCRP. This consortium drives several awareness campaigns annually called Aware for All. The goal is to promote clinical trial participation and research, advocating for diversity and inclusion in clinical trials. In addition to the Aware campaign, we've also joined a cross-sponsor collaborative focused on diversity and inclusion in clinical trials under the same sponsorship and leadership. The group is composed of other pharmaceutical companies and CROs to share best practices, identify barriers in clinical trials, and co-create actionable solutions. You can't effectively serve a diverse population if your workforce does not adequately reflect it. Diversity is a requirement of the business we're in. As a nation, we must not rest until every person in America is treated with the same level of dignity, respect, and basic human rights. This is not a partisan issue. This is a human rights issue. There is no middle ground. This is about doing what's right and having the courage to effect real change to combat institutional racism and social injustices. We've seen the power of solidarity as diversity, equity, and inclusion have come to the fore in the hearts and minds of Americans. But there is so much more to do. We must be vigilant in staying the course towards a more inclusive tomorrow. Slipping backward is not an option, and we must persevere to do better, to be better collectively. As a company, Otsuka will not rest until the full measure of each mind is realized through products, programs, policies, and advocacy. Our purpose statement continues to be our North Star. Defy limitation so that others can too. I truly appreciate your time and attention. Thank you once again for being here and engaging in this important forum. And now it's my great pleasure to introduce Deborah Barrett, Vice President, Corporate Affairs at Otsuka. Deb will lead you through the rest of the day's activities. Please enjoy the day, and I look forward to all your contributions. Thank you.
Thank you, Kabir, for your introduction and your leadership. And thank you to all of our participants and attendees for joining us today. I joined Otsuka last summer to build a new corporate affairs function, which was energized by Kabir and our leadership's commitment to prioritize and participate in advocacy in order to better serve our patients. Our new function connects corporate communications, corporate social responsibility, government affairs, and patient and stakeholder management so that we can maximize our engagement with policymakers, partners, and stakeholders like the community that joins us today. Otsuka knows that well-informed and focused policymaking is critical to delivering on our mission of bringing better health to patients. That is why we created and continue to host this annual policy forum to discuss some of the most pressing issues and challenges in mental health care. Earlier in my career, I sat at tables like this as a healthcare staff member for now Senate Majority Leader Chuck Schumer of New York, former Senator Chris Dodd of Connecticut, and Senator Patrick Leahy of Vermont. I remember how valuable it was to engage with leading experts, frontline advocates, and varied stakeholders in order to find policy solutions that enhanced healthcare access, delivery, and outcomes. Otsuka is committed to continuing this work as one of those key stakeholders and to supporting the pull-through of the best ideas to implement change for those confronting mental illness. As a company, we commit to working together with you as a resource and a partner in these efforts. Today's event is significant for many reasons, not the least of which is that May is Mental Health Awareness Month, a time when we rightfully place mental health discussions on the national agenda. And we recommit to a shared vision of a nation where people living with mental illness get the care and support they deserve to lead a healthy, fulfilling life. Fortunately, this conversation is happening all around us. In fact, as we host this discussion today, the Senate Finance Subcommittee on Healthcare is holding a hearing on the impact of the COVID pandemic and the growing need to improve mental health and addiction services in our communities. Hearings like this and others allow us to share best practices and specific challenges and work collectively toward a system that meets patient needs. As Kabir noted, America is in a mental health crisis. As a recently released GAO report demonstrates, the COVID-19 pandemic has only exacerbated the mental health challenges we are facing. The CDC household pulse surveys, which were conducted from April 2020 through February of this year, found that on average, 38% of adults reported symptoms of anxiety or depression. That's up from 11% of adults in January to June 2019. Unfortunately, despite an overwhelming need for services and Herculean efforts by this policy community to direct attention to that need, the RAND report that Kabir mentioned found that just 45% of people in the US with a mental illness received any mental health treatment. The story is even more disturbing for members of racial and ethnic minority groups, who are about half as likely to use mental health care as non-Hispanic whites. Prisons and jails are now recognized as the largest institutional providers of housing for people with serious mental illness. In addition, there are striking geographic variations in the availability of mental health specialty care, with rural areas particularly underserved. Otsuka has a long and deep commitment to meeting the needs of people suffering from mental illness, especially underserved populations and those in jails and prisons, of which nearly 45% have a history of mental health challenges. Otsuka supports the Sozosei Foundation, which is working today to address the decriminalization of mental illness in the United States by encouraging best practices and innovation in diversion and reentry, by reducing the stigma of mental illness, and by improving care for people with mental illness while incarcerated. We are really interested in addressing the systemic inequities within our healthcare system that limit access, and we want to find ways to simplify the journey for both patients and providers, making it easier for them to learn about, enroll in, and participate fully through patient access services. In addition, as Kabir mentioned, digital innovation will be a key factor in helping to bridge some of these gaps. Otsuka has long prioritized digital health solutions. We continue to be optimistic about the possibilities that digital innovation can provide patients when it comes to managing, understanding, and collaborating with their providers on their treatment journey. We're committed to exploring digital innovations and technology that have an impact on patients' lives, especially in a population that has critical unmet needs, like those living with mental illness. That is why I am particularly excited about our next speaker, who is a leader leveraging digital innovations in service of mental health care. Our keynote speaker today, Dr. Nina Vasan, is a practicing psychiatrist, entrepreneur, and pioneer in digital mental health innovation. As a clinical assistant professor of psychiatry at Stanford University School of Medicine, Dr. Vasan is the founder and executive director of Brainstorm, the Stanford Lab for Mental Health Innovation. Brainstorm is the first academic laboratory dedicated to transforming mental health at scale through tech-enabled products. Dr. Vasan is also the chief medical officer of Real, a new startup founded by a former student of hers and launched during COVID-19 that provides a digital suite of mental health services for less than $1 a day. Dr. Vasan's policy experience is rich, serving on the health policy advisory committees for both the Obama 2008 and Biden 2020 presidential campaigns, serving as an expert advisor for the United Nations on inclusive social policies for mental health, and working in the office of the Director General, Dr. Margaret Chan, at the World Health Organization. And Dr. Vasan's voice is being heard as she was recently featured on popular podcasts such as The Armchair with Dax Shepard, one of my favorites, and the Goop podcast with Gwyneth Paltrow. I was fortunate to sit down with Dr. Vasan yesterday and ask about her insights, her experiences, and her recommendations. We're going to share that pre-recorded conversation now. Dr. Vasan, thank you again for joining us. You are first and foremost a healthcare provider, a psychiatrist committed to serving patients in need every day. So I really wanted to start there. We have noted the incredibly disturbing impact of the COVID pandemic on the mental health challenges we face as a country. The first half of 2019, I think the statistic is 1 in 10 U.S. adults reported symptoms of anxiety or depression. Today, that number is more like 4 in 10. And those statistics go on and on and on. We've seen increases in substance use, suicidal ideation, etc. Can we start with you telling me a little bit about your experience in your practice as a provider on the front lines with your patients?
Absolutely, Deborah. I would summarize by saying profound pain and profound resilience. And that's really what I was struck by, because some of my patients I've known for years and years, people who survived genocide, veterans of our wars, who have seen some of the most devastating things, strongest people we have in our society, who then were in such immense pain that for the first time in my entire life practicing, showed up to our appointments under the use of substances, because that's just how much of a struggle they were in. Yet at the same time, I think what I was just remarkably inspired by was the ability to thrive and flourish and find positivity at such historically challenging times. And Deborah, what I think really strikes me is the immense generosity and kindness of everyone, especially I think back to the beginning of the pandemic when we were all struggling and we were all so lost and scared, and how people were helping so much and just trying to see any way to help their neighbor, to help anyone less fortunate. And that sense of who we are as people and how we thrive and rise to the occasion, the goodness of humanity, that's really what the number one striking thing I have is that. And I was just so blown away to see that in my patients.
It's inspiring. How did you adapt given the realities of what you were seeing as a provider?
Yeah, it was really interesting and really difficult because usually as a clinician, we're trained where our patients might be struggling, but we're not simultaneously going through those exact same challenges, right? I'm in Palo Alto in the middle of Silicon Valley, and technology is booming all around us, but California, after New York, became one of the hardest hit areas. And so just as my patients were concerned about the risk of infection, I myself was trying to get groceries and making sure that I was protected. And so I think having that shared experience was definitely very new, but it also was then scary because I was not able to, I wasn't prepared on how I could help them because we were all learning things at the same time and having to tune into the news and, be on the same page in a lot of ways, versus usually as clinicians, we kind of are in this almost position where we know a little bit more than our patients. And I think that ultimately what that really just showed was the vulnerability of all of us as healthcare providers and how what an immensely challenging struggle it is. I do have to be very grateful for the focus we've now had on the importance of self-care for the healthcare professionals, because it's something I have not historically done well and really am trying to push forward myself. There's a saying, physician, heal thyself. And that's really, unfortunately, what we learn is that we're not allowed to be sick as doctors because we're taking care of everyone else. And so I do hope that that's a cultural change that we see.
As you've noted, our lives have certainly changed significantly over the last year, right? And in so many ways, the mental health care system has been stretched to its limits. But of course, daunting challenges spur innovation and even more commitment. So let's start with what we've done right. What are the things you've seen that we've created that more access and opportunities for patients in need?
The first thing that I would actually say has been a huge win from the quarantine has been policy. And knowing that I'm speaking to a group of policymakers, I have to say on behalf of all of my colleagues, the biggest thank you for how you have completely transformed healthcare over the past year. Usually as a doctor, so much of our relationship with policy is feeling frustrated by challenges and barriers. It was the exact opposite this year. Changing things like reimbursement for access to telehealth, where, before telehealth visits were not even covered or were covered at a much lower cost compared to in-person care. Dissolving state boundaries. And as someone who grew up in a small town in West Virginia, where, access to care was completely different, dissolving state boundaries completely was a game changer when we think about the supply and demand mismatch and being able to offer care to rural areas and really just, change the way that we as a country are able to deliver care. And then, of course, changing of HIPAA and at all levels, federal, local, and state, all the initiatives that were out there. Policy truly, as I said, just the MVP, if you will, of the quarantine. So that's definitely number one.
It's good to hear. We've made a lot of progress and a lot more to go, right?
Exactly. Yeah. Number two, I think, is technology. And what's really interesting here is it's not that it was new technology, it was how we use that technology. This is technology from 10 or 20 years ago that we were using, but it was the fact that now it's like, into the entire field of healthcare, like literally overnight moved all online, right? And not just things like that, but now things like Amazon and Instacart, and like the fact that we are literally, everything is being delivered to us at home, and there's this in-home access of goods and services, and really just changing the way that we engage with every element from, work from home and everything, really going to that virtual environment. I think that definitely was something that we did well in terms of everyone being able to navigate and evolve so rapidly to the crisis that we were dealing with. And then I think the third thing was community, because, we were already in a loneliness epidemic, Deborah, before the quarantine. And so then to be in this state where we're all like, locked in our houses, the ability to create community, especially through things like social media, I think was a really cool win. And then I guess maybe the final thing I'll say about that, on sort of an extension of community, was collaboration. We saw collaboration between sectors, between entities, people who had maybe been enemies before, or competitors, work together in ways that we've never seen before. And I think that in mental health, where historically we've been so siloed, that is tremendously important, and we have to build on that moving forward.
Agreed. You mentioned social media, and I want to pick up on that thread. One of the concepts I've heard you talk about before is really that when we consider improving our mental health care system, that we need to meet people where they are. And I have to imagine this is especially true when it comes to the use of technology and social media moving forward in particular. Can you share some thoughts about that?
Absolutely. I'm fortunate to have had an early start at this idea of meeting people where they are. 20 years ago, I was actually college classmates with Mark Zuckerberg. And so I was one of the first people to join Facebook. And having been one of these early adopters and seeing how it completely transformed society, created new opportunities, everything from launching social revolutions to solving problems in ways that nothing else can. And so when we think about this idea of meeting people where they are, that includes everything from telehealth to social media. And even before the pandemic, people were going to places like TikTok and Instagram and talking about their mental health. They were finding community and seeking solutions. And so when we say meet people where they are, that's literally like, let's go to them online, because that's where they are living their life. Yes. And when it comes to policy, I think that when we think about social media, a lot of what's talked about is the harm. And it is really important that we figure out, how do we restrict social media companies? However, the biggest value that needs to be explored is the potential of these companies when it comes to mental health to actually do good. Right. Because there's, I think, a historic opportunity when we think about the platforms that have been built. 3 billion people, half our world, are living on these platforms. And so what can we do that the healthcare system cannot? And how do we leverage these platforms and the unique ways that they've engaged us and actually educate people and prevent and treat disease? And then where does policy come in to help make this happen? So I'd love to actually give an example of what my team at Stanford did with Pinterest. So Pinterest has about 450 million users. And when most people think about Pinterest, they might be, thinking about planning a wedding or designing their home. And what it turned out actually is that when Pinterest looked at how are people using their platform, it turned out that the 4th most common category of search terms was related to mental health. So while people weren't really thinking about it as a mental health tool, that's what actually they were seeing. People were searching for things like depression or anxiety or stress. And so what we did was we partnered with them and actually took the same sorts of treatments and therapeutics that we would do in clinic with our patients and brought that to the platform, so that now on Pinterest, if someone types in something like depression or tools for stress, they can actually take the same evidence-based treatments and do something on the platform in just a few minutes. And this is called compassionate search. How do we change the search experience so that it actually creates this experience that promotes someone to actually talk about their mental health and get help in real time? And the idea here is that, can we create an opportunity to actually leverage this platform where millions of people are going and give them the same resources that they might get when they come see a psychiatrist, but instead get it, on their phone, right? And get it for free in the minute that they would actually need it. And so be able to use it instead of having to wait, days or weeks or months to have to see a doctor.
I was going to say, in real time, the reason we like social media and technology to begin with is having access to it when we need it.
Yeah, absolutely. And I think that's actually what makes this really, really unique and special is that when we think about when are we struggling the most, right? It's not usually when you're seeing your doctor. It might be like midnight on Friday when you need some help. And so when we say meeting people where they are, that's literally what we mean is if we can provide things like 24/7 access through something like social media, if we can, educate people in ways that they're able to look for things or actually give them treatments that they can just find and search in a safe and secure way, then that gives them that immediate access to care that they need. And when we look worldwide, as staggering as the numbers are in our country, worldwide, 60 to 90% of people cannot access mental health treatment. Okay. But then when we look at something like social media, we know the majority of the world are on these social media platforms. And so social media, I think, then really provides a compelling opportunity to address multiple challenges when we think about access. It's things like the supply and demand mismatch, it's stigma, it's cost, and even when we think about cultural sensitivity and the importance of customizing treatments for particular countries and languages and cultures, we're actually able to do that at scale in a way that's incredibly difficult and cumbersome for the healthcare system to do. This is why I think technology is so cool. It's really like this ability where technology is not just about copying and pasting what we do in brick and mortar healthcare. It's about taking that next step and thinking about what are the unique opportunities to reach more people, reach them when they need it most and where they are, and really then redefine how they're able to understand and engage in their health and well-being.
Which increases the value in it from every front.
Absolutely.
Let's spend a few more minutes on technology. I know we have a great panel coming up a little bit later today, and it's a topic that is near and dear to you and your work at Stanford. The pandemic definitely showed us the value of balancing innovation and regulation, finding and creating the flexibilities that put patients first and their needs first, but also ensuring that we still allow for that free flow of innovation and new improvements. How do we carry this momentum forward?
Well, there is a whole world beyond telehealth that can completely transform the way that mental health is talked about, prevented, diagnosed, and treated. And the chair of my department at Stanford, Dr. Laura Roberts, actually has a quote that I say a lot, so I'm gonna quote her here. Allowing the marketplace to govern issues related to well-being of the public is simply not sufficient. It is an injustice not to innovate. So when we think about then these issues that we're dealing with, we really have to think about innovation very, very broadly and push forth that innovation. And that's where policy comes in, of recognizing the unique role that policy has in order to foster innovation for well-being and mental health and all of the kind of human rights issues that we have when we think about these inequalities. Now, the FDA actually has a new Center for Digital Health Excellence led by Bakul Patel. And I think this is a really great step in industry, academia, government collaboration. We need to find a balance. We need more funding and policies like Medicare and Medicaid reimbursement to create the financial environment and incentives for innovation to foster. But then we also need to make sure that we have regulation around things like efficacy and safety so that we're not doing any harm and really moving the needle forward. And one of the examples that I think is really awesome, last year, we actually saw Senator Shelley Moore Capito, who's from my home state of West Virginia, introduce a bill around funding prescription digital therapeutics. And I think that was really landmark innovative legislation to get out there. And I expect that we'll see it again this year. That was a really foundational and important step forward. And what I loved about it, it was a bipartisan effort and really just being able to show that policy can understand technology and give technology the space to solve problems and increase access in a way that nothing else can. So, we've talked already about the supply and demand mismatch. And at the end of the day, we simply do not have enough clinicians. we have to think really creatively about what we can do here. And while, there's certainly programs to try to increase the number of clinicians or make us kind of marginally more efficient in different ways, that's all great, but that's really just a drop in the bucket. Technology-enabled solutions are able to expand the reach of clinicians and do it at scale. And so telehealth has, already now become standard of care. But there's so much more that we can do. And that's where that's just our new starting point now as we think about the next steps. So you asked, how do we carry this momentum forward in putting patients first? And I really love the way you said that, is how around putting patients first. Because there's a quote I'm going to say, Sir William Osler. So he's the father of modern medicine. And he has this quote: "A good physician treats the disease. A great physician treats the patient who has the disease." Now, he said that 100 years ago, and it's just as important today when we think about what's really needed, because the reality is that the center of the healthcare system is still disease. And sometimes it's even the system itself, meaning that's what gets priority. And instead, it needs to be the patient. We need to design and create policy and a whole system where the patient and the person is center. Now, let's think about something like therapy. When you need help, it's not at 3 p.m. every Wednesday, which is when therapy appointments occur. Usually when you're really struggling, it's midnight on Friday and you're unable to sleep, you're doom scrolling, and you're upset about a fight that you just had. That's not when therapy appointments are. And that's what we need to change if we think about the way that kind of healthcare is delivered. And that's where technology comes in being able to offer, increase access and offer new solutions. So that's actually what we're doing at the startup I'm working with, Real. We're really trying to reimagine, what does mental health care look like? What do services look like in new ways? And when we think about the barriers to care, how do we really put the patient first? And what are those barriers? Cost is number one. We're changing cost structure so that cost is less than $1 a day. If we put the patient first, that means that there are options for people in terms of what to do. So at Real, we're offering a whole range of ways that you can engage in treatment, including groups and self-guided care. And so when we think about meeting you where you are, it's about giving you all these preferences that you can engage in. And then, when we think about reimagining care, I was talking about that, this one-on-one model is based on convenience and scheduling and business models. It's not based on what's best for science. It's not based on what's best socially. It's not based on what the patient actually needs. So if we're going to continue putting patients first and front and center, it means that we have to just really create a whole system around this. And then I think the final thing I'll add here is that if the person is first, then we need to create a culture that is proactive instead of reactive. Putting a patient first means that you're not always like in crisis and trying to put out fires. And crisis response is so, so important. And I'm really grateful for the panel that you have later today about how that is just completely changing and going to really transform what crisis response looks like. And in addition to excellent crisis response, the whole culture of mental health needs to change so that we're treating it like other diseases. Like if we look at something like cancer, right? We're trying to prevent cancer. We're trying to identify it early and give people treatments like that. That's exactly what we need for mental health care.
We're looking at the system holistically and what the needs are holistically. Makes sense. You sit on the front lines as a provider, but you also sit on the front lines in terms of innovation in the mental health space. Based on your work at Stanford and in the many other projects and the other work that you do, can you give us a little peek into what you see? What are some of the things that are most exciting to you or most interesting to you that give us a sense of what might be coming down the trail here?
I would love to. So at Stanford, we're exploring all kinds of new digital technology, and it starts with mobile apps, but there's much, much more. So there are digital devices, sensors, augmented and virtual reality, artificial intelligence. Just think about all the technologies that you're hearing about that are changing everything from, gaming to food delivery to, kind of everything out there. That's really what we're seeing. And what I'm so excited about is let's bring that to mental health. And through my lab brainstorm, we've seen a huge increase in innovative ideas for creating tech-enabled tools to tackle the mental health impact of COVID. And one of the most exciting things here is that, it's not just about copying digitally what we do in healthcare, but it's actually about leveraging the unique characteristics of these technologies to solve problems in brand new ways. So I'll give you some examples. Let's start with something like diagnosis. Now, right now, the norm for diagnosing something like autism is months of disruptive testing. It's a long, long wait list. But now, thanks to very cool technology around computer vision and artificial intelligence, we can actually diagnose autism from a short 3-minute video clip of a child playing outside. Very cool, right? It's very, very cool.
Amazing.
It's amazing. And then if we think about something like treatment, we all have smartphones, and we can continue to see efforts that, if we think about access, right? Like there are these great efforts to federally enhance broadband services. So things like mobile apps that offer cognitive behavioral therapy and psychotherapy options, where patients at their own time, their own pace can get care, and not just, it's really personalized care. And one of the things I think are really cool are things like chatbots, where we are personalizing to communities of color. We're personalizing to postpartum women who are postpartum. We're looking at languages where we don't have enough providers, and really customizing so that no matter who you are, you're able to get care that you need in your own way, and that's what technology is able to do. And then if we think about something like prevention, we're able to track things like your texting patterns and identify your risk for diseases like Alzheimer's or depression. And when you think about the public health benefit of something like this, it's incredible. And the best part about these solutions is that they're really easy to use, they're affordable, and they can be standardized and scaled.
Can you say a little bit more about the texting piece?
Yeah, absolutely. So this is actually one of the things I think is really, really cool. So if we think about our phone, now there's so many things that we do on our phone, so many behaviors that we have that in the history of healthcare and history of medicine, we've actually never captured before. Right now, if you go to your doctor, if you go to your psychiatrist or therapist, they're asking you questions like, how did you feel? How did you sleep? But now, because we have this device with us 24/7, it's able to track nuances of our behavior that we never even thought to track before. And so everything from things like your texting speed, your typos, your GPS tracking, all these sorts of things it's able to track. And what we're now able to do, what researchers are doing, are trying to then correlate all of those different patterns with disease. Right? So if you're typing quicker, how could that potentially relate to having some manic symptoms perhaps? Or if you're not moving around in a geographic vicinity, could that mean that you're more depressed? And so right now it's a lot of correlations. For example, if you're not moving around, maybe you're binging on Netflix, maybe you're not actually depressed, right? So we need to actually be able to understand the data on a very nuanced perspective. But the point here is that there's so much data that we're able to collect now. And I say historical because that's truly what it is. I always make these analogies to cancer. And if we think about when the X-ray or MRI was discovered, it allowed us to look into the body and see tumors at their earliest stages. And that totally revolutionized cancer treatment. That is what is happening right now with technology, is that we are able to look at human behavior through this phone and understand elements of mood and behavior that we just never have before. And so then to be able to use that to diagnose, treat, give people new therapies and treatments, new ways to understand what's going on with them, I think that's the most exciting thing about the future of mental health.
Absolutely. So I could continue hearing about the innovation for much longer. Thank you for sharing that with us. Of course, we know that to take advantage of this innovation, we need improvements in the system that delivers that care. So let's talk a little bit about what you think needs to be done.
Yes. Now, the first is equity and access. Society has had an overdue, but also very welcome social awakening this past year when it comes to diversity, equity, and inclusion. And it's clearly time the healthcare system undergoes the same reckoning. We've never experienced a moment like what we're in right now with the quarantine, right? And the data shows just how difficult this year was for all Americans. But in minority communities, everyone was hit harder. There were more risks, more loss of jobs, and we have to acknowledge this and start from there. It was really disparity building on disparity. And minority communities not only are having to deal with higher rates of mental illness, higher rates of suicide, but also are half as likely to receive mental health care. So as we think about solutions, diversity cannot just be an add-on, but has to be built into the very fabric of every solution. And now when we think about policy and innovation alike, we need to look at all these barriers. We need to look at external barriers like cost, access, transportation, racism, bias, and internal barriers like stigma, motivation, cultural fit. And innovation and technology can be designed to address these and really be further customized to marginalized groups. I'll give you a couple examples. I think there have been some really cool technological innovations that are focused on increasing access in underserved communities, specifically designed by founders and engineers of color. So like there are these really cool TikTok and Instagram accounts like Black Girl Therapy, therapy for brown girls, Latinx community, decolonizing therapy, hashtag for all of these. And, all of these are really getting out there, created by people of color, for people of color. And we have seen Black founders who are creating companies that are leveraging tech platforms and all to connect people of color to Black clinicians. And so if we want to meet people where they are, they have to feel safe being met. And I think that that's really what this is about in terms of how can we create a better opportunity here. And then the final thing here around, equity is that there's a huge role for media to address access here. If we think about the words that get associated with mental health, we need to unlink mental health with criminality. And especially this hurts communities of color disproportionately. So it needs to be it's so much harder to have a discussion and encourage people to get help when we talk about mental health in the way that we do. So every time there's a mass shooting in our country, mental health gets blamed and further stigmatized. And we need to remember that people who are struggling with mental illness are more likely to be the victims of violence than the perpetrators. We need to have these conversations. And that's really just where I think we can see big changes as it comes to equity and inclusion.
So you referenced stigma. Say a little bit more. I mean, this is something we've been talking about for a long time, and yet it continues to be one of the major issues here. Can you say a little bit more about that?
Absolutely, Deborah. And I think that mental health is undergoing a renaissance. This is the time I feel like I've been waiting for my entire professional career. And it's really because we're rewriting the conversation around mental health. One of the things I've said from the very beginning is that of my career is that when I think about the challenges of mental health, that stigma is problems 1, 2, and 3. Mm-hmm. And through the pandemic, we've seen a decrease in stigma, rather this acceleration in the decrease in stigma. And I think the way we're talking about things today is what I thought we would see 5 or 10 years from now. Stigma has been such a barrier. And it's unbelievable to me the way we talk about mental health, especially when we think about how many people are impacted, right? 50% of Americans will have a diagnosable mental health disorder over the course of their lifetime. So when it's something that's so prevalent, why has it been talked about like it's someone else's problem? Yet the quarantine really did change things. And I think that's been one of the awesome silver linings of the pandemic. I start my day on NewYorkTimes.com. And before the pandemic, probably you would see an article related to mental health maybe once a week at max. Now, every single day, there's something around mental health, or maybe tips for mental health or well-being or wellness or something for parents. And I think that there's now an opportunity to build on this and do more, because mental health is on the public conscience in a way it never has been historically, and policy can build on that. Nearly every American has an awareness of their own mental health due to this past year of isolation in a way that they never have before. And so we need policy that can act on this opportunity and make the change that is so overdue. And the last thing I'll say about that is that, when we think about stigma, it's not just about making mental health acceptable and okay. I want to challenge us to go a step further. When I look at how Gen Z, how they talk about mental health and how amazingly progressive it is, they're not trying to just normalize mental health. They actually celebrate it. They talk about it as a source of strength. And, that actually inspired me. I actually changed my own LinkedIn profile. And now I put my lived experience as the first thing on my LinkedIn. I have my work at Stanford, my kind of professional work, but I put that as the number one thing because I saw how they talk about it, and it really inspired me to change as well. We need to celebrate mental health and mental illness, and we need to throw parades and cheer for people and tell them that we're proud of them and they inspire us for getting help and getting treatment. And that's really the next change we need to see.
We have had a great conversation today, learned so much, and appreciate your time and your thoughtfulness. We hope that this is the first of many more conversations and an opportunity to work together. As we move forward and have our panels this afternoon and then do lots of work beyond that, I just wanted to ask you to kind of leave us with what you think are some of the top lines or the key insights that we need to keep in mind as we move forward and do this work.
I would love to. And first of all, just thank you very, very much. This has been such an honor and pleasure for me to get to have this conversation, and really look forward to the panels and just getting to be a part of this community as Otsuka has really, really been such a champion of innovation. Thank you. So first, to answer your question first, we have to ensure that we don't go back to the way we were before. The pandemic put mental health under the microscope, and it threw gasoline on an already smoldering public health issue in the US. The need for systemic change has never been greater, and we're making amazing progress in technology, stigma, understanding, and policy that will really help address the long-term solutions, the disparities in care, and the need to meet patients where they are. So we can't lose ground, and we need to actually really resolve that this sense of urgency is what we need to continue building on at this very moment. And that means meeting people where they are, whether it's at the forefront of technology or establishing a system of care at the community level through crisis systems. There's so many opportunities, and we really have to just take advantage of that. As we look to tomorrow, COVID has given us the opportunity for a societal reset. We all hit the pause button this past year. And it's given us the chance to rethink a lot of assumptions about how we live every day of our life, how we live, how we work, what every part of our society looks like. As we do that, let's apply that to mental health and think about how do we build a future that is healthy for every single American. And just as we're making all these changes, what does it mean? What are the assumptions we've made? Just like when we think about telehealth and how overnight we actually made these changes, even though it had been around for 10 years, right? All these policy changes that have now transformed the way that we can practice. What are the assumptions we've been working with, and what can we do differently? Policy has the ability to push us forward as a society and create a better future. So in closing, I'd like to bring us all back to this as a reminder, which is mental health is the greatest thief of human potential today. So what is the role, or rather the opportunity, of policy, but to help every citizen reach their potential? Otsuka has committed to that, of respecting the value within every mind and working to realize the full measure of each mind. Scientific discovery allows us to give this gift of human potential. Clinical medicine allows us to give that gift. And policy, that's what policy can create, really more than anything else we have. Now, this year has shown many people for the first time how their mental health limits their potential or the potential of a loved one. Yet we're still treating mental health like it's second place or even sometimes last place on the list. One of the statistics that I've been saying over and over again this past year, because I find it really alarming and interesting, is that if you look at the Great Depression, suicide rates actually peaked 3 years after Black Tuesday. Now we have to learn from that. Because if we can predict anything, it's that we have yet to see the worst of the mental health crisis related to COVID. We need to be proactive and vigilant in the next few years to tackle mental health, just like we have this virus. Because not only will it give people back their lives, it will help them realize their potential. Now, imagine a little Black girl who can discover the cure for cancer, or the trans boy who might be our future president. Instead of a world where both of those kids are struggling right now with cyberbullying or isolation, let's give them the gift of resilience and help them flourish, because they are the future of this country and they will create a new level of greatness for America.
Thank you. Thank you for inspiring us. Thank you for all of the work that you do, your commitment to patients in this field. We are better off for it, and we appreciate your time today.
Thank you very, very much.
Thank you, Dr. Vaslan, again for your thoughtful comments, for challenging us and inspiring us and raising some of the critical issues. I'm excited to jump into the conversations we're going to have next and do this work. I do want to underscore what Dr. Vaslan said about mental health being the greatest thief of human potential. I think that really captures why we're all as committed as we are. We will now take a quick break prior to our next session. In order to watch this discussion, which is entitled Technology Enabled Access to Care, please go back to the main dashboard of this event, click the session on your agenda, and then within the session page, a Join Session button will appear 5 minutes before the session begins. Thanks so much, and look forward to seeing you soon. Hello, everyone, and welcome back. Thanks for coming back for our first panel session, Technology Enabled Access to Care. Before we begin, I'm so pleased that Governor Charlie Baker of Massachusetts agreed to record a video to kick off this important discussion and share his experience seeking the emergency expansion of telehealth services in his state, just as the pandemic forced a shutdown last year. Governor Baker's leadership during this time underscores the critical role of technology in enabling access to mental health care services, particularly as this unprecedented pandemic threatened our mental as well as our physical health. In early 2021, Governor Baker signed into law a telehealth bill that mandates permanent payment parity for telemental health services and expands access for rural residents, people of color, working families, and young people. It's a great step forward. But as he notes, there is so much more to be done, especially as technology is really a new frontier for mental health support. Let's take a listen.
Good afternoon, everyone. This is Massachusetts Governor Charlie Baker, and it's an honor to be with you at this year's Mental Health Policy Forum. This event is a great opportunity to discuss crucial issues in the mental health space, which have taken on particular importance in the past year. I'm honored to introduce today's first panel discussion, Technology Enabled Access to Care. This will provide an important evaluation of the state of play on issues of technology, telehealth, and behavioral health access. As most people know, technology represents the new frontier of mental health support. It expands access to mental health services for millions of Americans and has tremendous potential to do so much more. Over the past year, we've seen just how crucial these services can be. The COVID-19 pandemic and the isolation that came with it created enormous behavioral health challenges for our residents. When we first required residents to stay home a little over a year ago, we knew it would be an important time for us to do something about their ability to continue to access healthcare services, including behavioral healthcare services. And despite being a national leader in healthcare, and by the way, despite the fact that this is where telehealth was actually invented here in the Commonwealth, Massachusetts had no formal structure for telehealth at the beginning of the pandemic. Just a few months earlier, our administration had proposed such a framework as part of a comprehensive healthcare bill that we'd filed with the legislature. But the pandemic forced us to act sooner, and we did. In March of 2020, literally within a few weeks of issuing our emergency order, I issued an executive order allowing for emergency access to telehealth services, recognizing that this would be crucial to ensuring people could continue to access care. Remember, at that point in time, no one wanted to go anywhere near a healthcare institution unless they absolutely positively had to because of the concerns people had about the unknown associated with COVID-19. This service, this ability for people to begin to engage remotely with clinicians, made a gigantic difference in people's ability to either start care or continue care under what I think we would all say were extraordinary circumstances. Now, the good news here is that patients and providers made significant use of this change. During the height of the pandemic, 75% of mental health clinical visits occurred via telehealth. For some behavioral health providers, as much as 90% of all services and treatment were delivered via telehealth during that time. After seeing these services provide a real benefit for people during that pandemic, it became clear to everyone that it would be necessary to sustain this new reality. Thankfully, toward the end of the last year, our legislative colleagues worked together to pass a comprehensive healthcare bill that codified many of the emergency measures we put in place way back in March as part of our response to the pandemic. One of those was ensuring a continuing framework for telehealth, and I was proud to sign that legislation on New Year's Day of this year. The new law requires coverage parity for telehealth services and implements permanent telehealth rate parity for behavioral health services. In addition, it requires rate parity for telehealth coverage for primary care and chronic disease management services for 2 years, and rate parity for all services for 90 days past the state of emergency. If the current trend of telehealth utilization continues beyond the pandemic, and I fully expect that it will, we can reduce costs for the healthcare system long-term by shifting care out of higher cost settings and giving people care where they need it most. Telehealth also reduces the potential for infections to spread, and we've seen fewer patients fail to show up for appointments. This is a really big deal, especially when you're dealing with behavioral health care issues and addiction. We believe this new law will ensure access to behavioral health services, especially for vulnerable and hard-to-reach populations, and for those for whom travel and transportation is always a challenge. I was proud to work with our healthcare community and our colleagues in the legislature to get these important changes enacted. Now, as we look beyond the pandemic, our administration will continue to prioritize both telehealth and behavioral health care services. In fact, we're working with the legislature on what we're calling a behavioral health roadmap, which I hope plays out over the course of the next several years. And we're committed to ensuring that people have the infrastructure to take advantage of the expansion of telehealth. For that reason and others, we've been working for the past several years to ensure internet access to all communities across our Commonwealth. And we've worked closely with our colleagues in Western Mass on the Last Mile program to ensure that they have access to high-speed broadband internet services. And earlier this year, we expanded a program that offers free Wi-Fi hotspots in some of our gateway cities, which have been particularly hard hit by both the health and economic impacts of the pandemic. We also remain committed to prioritizing behavioral health care services, and the healthcare legislation that we filed before the pandemic included measures that were designed to increase spending on primary and behavioral health care. It's because we know these services, first of all, are under-supported by the current system across the board, federal government all the way down, and they can help reduce costs and improve outcome for patients if used properly. As we look forward to the future of healthcare, we'll continue to collaborate with partners across our healthcare system to improve access and take advantage of new innovations. Conversations like this upcoming panel are crucially important as we assess the current state of play and evaluate how we can move forward and improve the system. So thank you for having this important discussion today, and I appreciate the opportunity you've given me to share a few thoughts. Enjoy the panel and the rest of today's program, and I hope you all have a better 21 than 20. Thank you.
We thank Governor Baker for his remarks and introduction. That video helps us really set the stage for our upcoming conversation. I'd like to introduce our first panel. Today, we are fortunate to be hearing from Mary Greeley, President of the Healthcare Leadership Council, Brian Scarpelli, Senior Policy Counsel of Health Initiative, which is the digital health advocacy arm of ACT, the App Association, and Nathan Tatro, Deputy Digital Director of the American Psychiatric Association. Here to moderate is Nora Belcher, Executive Director of the Texas eHealth Alliance. Thanks to everyone for being here, and Nora, I will hand the discussion to you.
Your time zone is to everyone. I'm Nora Belcher with the Texas eHealth Alliance. I'm delighted to be joined by these three outstanding panelists who have deep and broad expertise in healthcare coverage, mental health, and telemedicine, which is what we're going to talk about today. You know, the pandemic has really been a complete reframing of how we talk about digital health and virtual health, from where we sat 2 years ago to where we sit today. And so this has really changed access to mental health treatment. It's changed how we think about providing service delivery to all sorts of patients that might not have been on the radar for digital services in the past. So, and this is a conversation also that's playing out both at the state and federal level. Some very interesting discussions happening in both of those scenarios. So for the next little bit, we're going to dig into some of those questions. We're going to start by looking at the state and national policy level, and then we're going to get a little bit more granular. So I want to start with the big picture and with Mary Greeley from where she sits with the Healthcare Leadership Council, and sort of ask you to talk about how the pandemic has impacted access to telehealth. What do you see from the position of your organization? Maybe talk a little bit about that, where you sit and what you see. And let's maybe start there, Mary, if we could.
Great. Thank you, Nora. Well, I would say there's been an absolute explosion in the use of telemedicine and telehealth. Just citing one factoid from one of our members, Blue Cross Blue Shield of Tennessee, in a 1 month period in 1919, they had less than 4,000 claims for these services. And in the same month in 2020, that increased to more than 71,000. So just think of that, from 4,000 to 71,000 just in 1 year. I would say a lot of our members at the Healthcare Leadership Council, both the payers and providers, had been moving towards the expansion of using telehealth, but there were many barriers in the way. So as we heard from Governor Baker, this pandemic really drove the need for telehealth in a way that we hadn't even imagined before. And we saw the providers and payers stepping up and expanding their telehealth platforms. So it certainly has improved access for patients for all types of healthcare, but particularly in mental health. But we also have a clear recognition now of what are some of the barriers in the way that we also can talk about a little bit.
That's great. Can you talk a little bit more about how your members handled the pivot? I can tell you from my experience here on the ground in Texas, I had provider associations that overnight transformed their entire practice. I had one 200 plus group of doctors that went completely virtual in like 7 days, which was extraordinary. I'd never seen anything like it. And I've rolled out a lot of telemedicine projects in my life. Talk a little bit more for your members about the pivot, and then I want to pivot to the policy component.
Great. Well, the Healthcare Leadership Council is an organization that represents all the different sectors of healthcare. So we've had sort of a bird's eye view of what's happening in telehealth. One of our members is TeleDoc, who has been a real pioneer, leading the way in this in terms of facilitating it. But I have to say our members on the provider side and payer side tend to be the early adopters. So many of them have been creating the virtual platforms, but boy, they had to deploy immediately and much wider than they had originally planned. So a lot of it was acceleration of these platforms. And you're right, it was pretty amazing to see how quickly physicians and health systems were able to acquire these tools, implement these tools, and that was coupled with the federal government and state governments granting a lot of waivers that help pave the way for being able to implement this as well. So in the mental health area, I think we're all aware, and I'm sure Nathan will be talking about this a little bit, that there has been a shortage of providers of mental health services. And so this really made it much more efficient and much more available to that population. But we have seen this in every sector of healthcare, the need for this. And I'm gratified to see that I would say the genie is well out of the bottle and it's not going back into the bottle. This has been a very patient-centered approach, very consumer-oriented approach. They like it. And I think we're finding some physicians, some of them who happen to be in Congress, who really had not been huge supporters of this approach, are now what I would call true believers. They've seen how it has worked, made the system more efficient, and I think of a higher quality and better outcomes for those patients and consumers.
So I completely agree with you. I think this is like the world's largest pilot project, right? Done in about 12 months without anybody really planning for it to be a pilot project. So I'm going to talk just a little bit about our experience on the ground here in Texas, and then I want to pivot to the question of policy for all of the panelists. Then we're going to give Nathan and Brian some time to talk about kind of technological evolution. I certainly think one of the things that we saw on the ground here is how our vulnerable populations, how underserved they really were until their traditional sources of care got cut off. That meant some use of audio only to support behavioral health, which we have legislation right now pending here in Texas that my organization is working on to make audio access only access permanent. We saw some waivers lifting state-by-state licensure requirements, and I think there's going to be a pretty big ongoing policy debate about the role of licensure and how that works going forward. We certainly have found applications of telemedicine that were things I'd never dreamed of. Two of my favorites were music therapy for people with disabilities is a benefit in the Texas Medicaid program. Our largest music therapy provider has gone 100% online. She's telling me she's not going back. It's less windshield time for her therapists. It's better outcomes for her clients. It's keeping everybody safe. Very well documented, very well studied, and a really terrific development. And quite frankly, I've been doing this a long time, music therapy, not on my radar, not something that I was out sort of aggressively pushing telemedicine and telehealth policy for. So I think that's important. I would also say that a survey of physicians in Texas tells us that 80% of Texas doctors who've been doing telemedicine plan to continue to do it. So if I can keep 4 out of 5 in our tent providing virtual services to clients, I think that that is an outstanding development. And I think to a certain extent, patients are going to vote with their feet. I've been comparing this a lot to, do y'all remember when America Online sent everybody a CD-ROM? It came in your mailbox. My grandmother thought it was a coaster and she put her iced tea on it because she wasn't sure what it was. But all of a sudden, everybody you knew, your aunt, your uncle, your neighbor, was online. And this has been the same experience for telemedicine for patients, I think, a modality that they might not have had exposure to, they've now been exposed to. And so the policy debate at the national and state level is what do we keep? And how do we make this work going forward, given that it's such a big shift? So I think with that, I want to pivot a little bit, bring Nathan and Brian into the conversation, but start with, on the policy front, Mary's talked a little about her multi-stakeholder group. I've talked a little about what it looks on the ground in Texas. I want to have you two start by commenting a little bit on policy and where you see that conversation, and then we'll dig into some more of the questions around technology and the go forward. Nathan, you want to go first?
Yeah, absolutely. So from the policy side, you made a number of good points around, telemedicine, increasing access to care. A lot of that really had to do at the federal level. We saw really a relaxation of a lot of the regulatory burdens that APA has advocated in getting rid of over the past few years. So on the Medicare front, we know that the patient having to appear at a qualified originating site and having to reside in a rural area. Those were two pretty big barriers to care. During the public health emergency, patients were able to be seen in the home or at a location of their choice, and having physicians being reimbursed for that. Another policy issue has been, of course, along with Medicare again, is a licensure. So currently under the public health emergency declaration, any Medicare patient can see any Medicare doctor across the country, regardless of where the doctor's medical license is. The other policy issue we saw really mitigating barriers to care has been a relaxation of the Ryan Haight Online Pharmacy Consumer Protection Act of 2009, which requires an in-person initial examination by a physician before they can prescribe a controlled substance. Now, a lot of people think that's reasonable, but this act was really intended to crack down on pill mills. And what we saw it actually doing was was creating a barrier to care. So mental health, psychiatry, it's a different beast. It's a different branch of medicine that doesn't always necessarily require, hands-on physical examination. So Ryan Haight has these, 7 exceptions to it, one being the public health emergency. The one APA is focused on post-pandemic is really pushing the DEA to release a special registration process for the practice of telemedicine, which would also get rid of that requirement for an in-person examination before you can prescribe a controlled substance via telemedicine. So those are all the policy issues at the federal level we're focused on. There's a lot of legislation coming down the pipeline right now. Unsurprisingly, like I said, the genie's out of the bottle, and legislation that may not have gotten a lot of co-sponsors prior to the pandemic. We see lots of senators jumping on board. One we're focused on right now, you're probably familiar with it, is the Connect for Health Act, which is sponsored by Senator Schatz of Hawaii. And he actually had a version of this act back in 2017. Didn't really gain much steam, but now everyone's jumping on board. So that's really where APA is right now on all the policy front for the federal level. And of course, like you mentioned, each state has its own policy agenda, and we do have a state government relations team pushing out. I helped to develop some model legislation for states, and right now we have 26 states who are taking that model legislation for telehealth and putting it through the process. So that's where AP is right now in terms of policy and telemedicine.
So before I let Brian answer, I just want to say I've been working with your Drowned team in Texas, and they have been invaluable in terms of our fight to make sure that we keep a lot of this flexibility in place. So kudos to y'all for having a strong federal team and a strong state ground game. You have to have both in order to make this work because of all the complexities. So Brian, you want to chime in on the policy side? What do you see? Where are we at? What have we done? What do we need to do? So.
Sure. Thank you very much, and thanks for having me here. I think it's a very exciting time generally for the policy side of this issue. There's some technologies which I think many of us use in many other aspects of our life that have not yet been enabled for the healthcare sector, which have very recently, as I think some of the previous speakers have mentioned and others have talked about, been enabled using essentially emergency authority at the federal level. And it really has begged, if you're looking for a silver lining in a pandemic, which I always am, and I do hope the pandemic ends tomorrow too, but it really has really highlighted the range of legacy statutory and regulatory constructs that exist, and has begged the question of why they remain in place or why they have not yet been updated. Ranges from payment from major government beneficiary programs such as in Medicare, where we have seen some new breakthroughs aside from that actually precede the pandemic to support clinician use, responsible clinician use of greater of new technology-driven modalities past live voice and video. But I think also probably one of the shiniest object is one that Nathan mentioned too, with respect to live voice video, which is what Medicare considers to be telehealth and not other modalities. The restrictions in Section 1834M of the Social Security Act, which I sadly know offhand, which include the originating site restriction and geographic restrictions that effectively exclude the entire American population who do not reside in a rural area, suburban and urban populations, as far as Medicare beneficiaries from benefiting from receiving Medicare telehealth services it's long overdue that those be revisited, and they have been set aside by under emergency authority. But again, the inability of the agency to waive copays, which has emerged, I think, as one of the larger barriers, especially for more vulnerable populations. Legacy anti-fraud restrictions and regulations in regulation from HHS, and even I keep calling them legacy, but they are legacy privacy constructs, such as HIPAA, which is a sector-specific privacy and security body of statute, and then body of regulations, which is currently being examined for some reform. But it bleeds into some wider discussions that I think are really important to have, such as, is it finally time for a federal cross-sectoral privacy framework to be passed by Congress, and how should they address existing sector-specific privacy regulations? Not even just HIPAA, but GLBA for finance data, things like that. And I think that the exponential increase in uptake of technology-driven tools, including in the mental health care sense, has really gone a long way to prompt these conversations to finally be had, to be seriously had. And sure, there's lots of barriers, CBO scores and things like that, but the door is open for wide consideration of a lot of these generally. So that's really exciting, because I've been working on these issues for a long time, and I don't think I've seen as many options on the table as there are right now. Just looking at the technology, I mean, there's approximately 10,000 mental health focused apps available today, just through publicly accessible app stores that handle that aim to provide a wide range of unique services to respond to different needs, and trustworthy resources of data. Connecting with clinicians, certainly, but also connecting with peers. I mean, I can think of a great example of a member of ours who has stood up a peer network for veterans, mental health and the veteran community specifically, which is I think most would agree is a vulnerable population. Even things like meditation guidance, it's all growing a great deal. So how do we address? How do we responsibly enable these different new tools permanently? I think is the ultimate question.
I think that is absolutely the question. And I find it so interesting, Brian, that you use the term legacy technologies. I do a lot of work on sort of the IT modernization side of my state government, where they're still running Fox Pro. And if you're in the audience and you don't know what Fox Pro is, congratulations, you're younger than I am, and I'm happy for you. But we have a lot of legacy infrastructure in healthcare right across the board that hampers a lot of these efforts. I'm sure Mary and her members are constantly having to work to move their technology systems forward, both external facing and internal, right? Isn't that kind of an ongoing challenge?
I find it interesting. We're talking about legacy infrastructure as well as legacy laws and regulations. Interoperability. I mean, I don't think anything could have highlighted the need for true interoperability more than this pandemic. Such a great tool for early warning as to where there are going to be outbreaks. All this claims data that we have that can be analyzed, and then real-time interaction with providers of healthcare. So I think you're hearing a theme here of we've had all of this great flexibility during the public health emergency at the federal level, and then at the states granting these emergency orders. Our big fear is that once the pandemic is over, that these things go away. So we're seeing such a broad coalition. I think many more people are interested in this and working on it than had been previously, and all of the issues that you've just heard highlighted. Licensure, payment issues. I mentioned interoperability, fraud and abuse statutes. So lots of these things. This is a real opportunity, I think, to get it right in a way that we have all been lobbying for many years, especially with the Medicare program, making these services much more accessible. And I think we now have great real case studies to demonstrate their value. And when that fraud abuse issue comes up, one of our members, Ascension Health, they are servicing and they have data, and we all need to be collecting that data, showing that the patients that are accessing telehealth services are higher acuity and are getting better outcomes. So it's a great tool, and hope we can convince the Congressional Budget Office to score it appropriately.
We certainly have more data than we've ever had. And I think it resolves that chicken and the egg conundrum. Give me the data. Let me do the service with that population. Oh, your data is not for that population, so you can't do it. But if you don't let me do the service with that population, how can I ever give you data?
Yeah.
I'm sure everyone on this call has had that experience. But I also think while we're building regulatory frameworks, I want to key off something that Brian said. We don't build those frameworks to be enabling, right? We build them to be dislabeling. We build them because we're concerned about fraud. We build them because we're concerned about violating people's privacy. And we sure do not build them for tomorrow's technology. So I want to go back to Nathan and Brian. What is there beyond audiovisual, kind of like the seminar that we're doing right now, and we're doing some things with audio only for the folks that don't have broadband, but what is the next sort of realm of technology in mental health services? Because while we have the ear of policymakers, it can't hurt to be also saying we need to build frameworks that look forward. Like for me right now, that's a lot of work on value-based purchasing, because I think fee-for-service medicine is hugely problematic for telemedicine and telehealth. So I'm trying to get to the table on value-based purchasing in my state with my Medicaid program. But it's not just audiovisual services I want covered. There's other stuff that's being developed that needs to be part of the reimbursement and regulatory discussion. So back to Nathan and Brian, I think both of you have stuff to share along those lines. What is next while we're pushing, right? We should ask for everything. So what else do we need to ask for?
I'll take a stab at that first, real quick. So I think it's really funny that we're still walking around and we're calling these phones, right? They're not phones. What they are, they've become extensions of our bodies, and the technology embedded within them is not just, you're right, audiovisual, and Brian can certainly speak to this. There are a multitude of mobile apps out there with a variety of use cases in healthcare. Not just that, our phones also have, an accelerometer. Our phones have a gyroscope. And we're seeing more Bluetooth-enabled devices that can plug into our phones. And it's collecting all this health data, and it's going to be able to, the ONC interoperability rule is really promoting the use of FHIR APIs to connect patients' data into their providers' EHRs. So, coming down coming in the future, it's going to be more than just, an app that's going to track your symptoms of, say, depression, or helping you to keep on track with any substance use disorder treatments, such as eye cognitive behavioral therapy. We're even seeing technology now going into using AI and machine learning to diagnose serious mental illness like schizophrenia. There are a number of research studies, one I think out of the University of San Diego, which looked at prodromal patients with, so prodromal is, pre-schizophrenia, when you're having some, before your first psychotic episode, where they used machine learning to analyze thousands of patients' speech patterns and can identify prodromes in that sample. And so, the sky's the limit when it comes to tech. But the main thing is, so we know, I'll stop in just a second. We know all this tech is, all the potential of this. I think the bigger question is, how do people actually understand what it does? And I think that's going to be an important role for policymakers to begin to not just, craft regulations and payment models, but figure out how to educate the public about what these devices do and the data they collect, and how they can best connect the patient to a provider.
Yeah, I think you captured that really well. I agree with everything that you said, Nathan, and it's great that you point out the role of artificial intelligence augmentation and or driven, tools in utilizing all of this new data that is available, that is becoming more available, including because of because of standardized interoperability through FHIR, as you mentioned earlier too. For me, I think about it also kind of in the sense of modalities, in that people use video calls all the time just to even talk with their family and friends and things like that, and I think a lot of people are adjusted to that. And we've seen in data, even just to look at the Medicare program as a use case, because they have released, I think, a decent amount of data on this so far, the wide uptake in utilizing live voice video calls, and that's an important modality. There's no question about that. That's to me is less a augmentation of the care process, but really a replacement of an in-person visit. Now, not in all circumstances. I think it's important to recognize that there's always going to be some aspects of healthcare that would require a laying of hands, for sure. But to the modality angle, I guess, that I'm bringing up is I think that there's a great deal of potential with respect to asynchronous modalities. The idea that some kind of data can be either collected or input by a patient or collected automatically, and stored and then forwarded on to a clinician for tracking and trending and review, and ideally early intervention, is I think holds immense value and in improving outcomes and cost savings. I would mention that if you look at the Medicare, again, I'm just running with the Medicare example, looking at the Medicare system, it's now been about 5 or 6 years since the agency, or maybe 3 or 4 years, sorry, that since the agency has provided unbundled payment for clinicians to use remote physiologic monitoring tools, and to pay not only for the technical component of the service, but the professional component, the review of the data, and then care planning and things like that around it. And I raise that because there's there's a scoping limitation there on what is physiologic data. I think most people would agree things like the glucose reading of my blood is a physiologic measure. When we start thinking about mental health, I think that there's some key use cases that are omitted there. And I don't necessarily think that was intentional in the development of that CPT code and its adoption by CMS. But where I'm going with this is I'm expecting, and I'm very hopeful, I'm crossing my fingers and my toes and everything here, because there's a new tranche of CPT codes that have been developed, and this was publicly disclosed in November of last year, to provide the same kind of incentives to clinicians in Medicare for remote therapeutic monitoring. And so I think of treatment of like substance use disorder and mental health aspects and things like that being encapsulated by those codes. And like it or not, I think that because of the sheer spend power of the Medicare system, it is something of a bellwether for private systems sometimes. So that's an important policy development, I think, to keep an eye on at the regulatory level. It's buried in a 1,500-page regulation that comes out every year, but that's one I'm really looking at.
Brian, I really appreciate that. I think as someone who's trained in CPT coding, I think if you don't understand how that coding system works and the impact it has on policy, I think it's really hard to do policy. Because I think we as a telemedicine community sometimes have been retrofitted into these face-to-face codes. And it makes a certain amount of sense if you're making the argument that you're using the same standard of care. But in some cases, you might actually be doing more because you're doing technology. So moving into codes that not only really capture and reflect the value of telemedicine, which helps Mary's members with evaluating value and helps all of us with services, I think it's also important, again, to look forward, because I know some of the cognitive behavioral therapy tools that are coming out don't have a code. And I've had stakeholders reach out to me to say, hey, how do I get Texas Medicaid to pay for this thing? And I'm like, well, you asked for a HCPCS code yet? And they look at me like, what's a HCPCS code? Like, okay, let's start there. Coding 101, what is the code? But back to the systems question, we have these big systems. We have claims systems and encounter data systems and systems that we use to track. In order to get that quantitative data, you got to have codes. So anybody who's on this call who's thinking to themselves, I don't need to know about CPT codes. Yes, you do. You need to know about them because they impact a lot of the regulatory and policy framework that we use to deliver even innovative technology. So it is important to pay attention to those 1,500-page rules. Don't they always seem to come out like right before major holidays?
Yes.
At one point, we were calling the Office of the National Coordinator the Office of No Christmas because it felt like they were always dropping rules like in December, and we're all spending our holidays educating our family members about interoperability because it's
on a Friday after 5 p.m. too, right?
I'm sure our colleagues and they're working really hard, but it's not easy to sort through that stuff to get to what matters, which is why I think discussions like this that highlight some of those things that might be buried are really important. And that leads me to my next question, really for all three of you. Speaking about things that got buried that people weren't paying attention to, the pandemic really revealed the digital divide, didn't it? The internet is now a social determinant of health. And your access to the internet is actually directly impacting your ability to access healthcare, not just during the public health emergency, but to a certain extent, even on a go-forward basis. So this is really for all three of you. Talk to me about your thoughts about technology and broadband and vulnerable populations. What are we doing and what can we be doing? This is certainly a huge topic in my state. Our telemedicine bill that does the COVID flexibilities is House Bill 4, which signals it's a priority from our House Speaker. Our broadband bill is House Bill 5. So we see those things on my state at a ground game level as a package. So I'm going to start with Mary. Talk to me about technology, broadband, digital divide. Like, where do you see that from where you sit?
I think there is a clear recognition now, more so than ever, of that digital divide. And we and many groups are pushing very hard for broadband expansion and funding to be part of the infrastructure packages that are pending, that are going to be pending in Congress. And I think we can make a great case for it. It affects healthcare, it affects education. And again, a clear recognition of that. So I really think that we will be successful in getting that funding. And another component of this was the public health departments trying to get data from hospitals and wanting to have that real-time data. The hospitals were extracting it from their electronic health records. Well, guess what? The public health departments did not have that infrastructure to receive it. So again, I think anytime we can make the use case, like give a clear example of what's working and what's not working, it is our job as lobbyists to really educate members of Congress and educate the public as well. And I think we have a great opportunity here to do it. I think there is a clear bipartisan recognition of the need to do this. So I'm optimistic.
Well, I share your optimism, Mary. I agree. I think the way that this has been framed is this topic has been framed is 100% correct. I do find myself talking often about different modalities that are either developed or developing that will enable all kinds of amazing innovations and improved outcomes and cost savings in healthcare. But when I think about it, a lot of those, when I'm talking about that, those proposals and those expectations can be almost academic if someone doesn't even have access to the infrastructure that they need to support such modalities to begin with. And sadly, with greater data coming in, including through broadband outage and deployment reporting through the Federal Communications Commission, I think it is becoming very, if it isn't already obvious, it's now extremely obvious that poor health statistics and poor broadband connectivity are no longer a coincidence. When you look at a resource that the FCC has, which it's a rather fascinating one. If anyone wants to go, just take a quick look at it. If you look up FCC Connect to Health 2 is a number.
And I think we should point out that this, too often people think of this as only a rural issue, and it's not. It's an urban issue as well. So I just wanted to underscore that.
It's true, yeah, and and so what is being done? I mean, the FCC as the independent communications sector regulator does have a statutory role in subsidizing broadband and communications connectivity for underserved parts of the United States, and there is a component of the almost $10 billion annual Universal Service Fund, which is I think about $800 million. So it's not the biggest part, but it provides connectivity to rural healthcare facilities only, right? It does not support, for example, connectivity in the home of a patient that would enable some kind of remote monitoring or other interaction. And that's due to statutory, again, we're stuck with the legacy statutory construct, the Telecom Act of 1996, which has limited the capabilities of the fund. With that in mind, Congress has passed in their COVID relief bills, they've given money to the FCC to fund deployments to for healthcare providers and their partners to address the most acute places where COVID-19 is affecting vulnerable populations in America. And they have specifically carved out this funding from the restrictions of the Universal Service Fund, which is a testament again to, I think, how this pandemic is begging us to look at these old laws and regulations and see, do we really need them anymore? How much more could we do? But they've already done one round of funding for COVID grants, and there's some really great stories and data from across the country in urban and rural areas, because they're not facing these restrictions with those funds. And now they're in a second round, which I believe either just closed or is about to close the application window. And they're very rapidly awarding these grants. So I'd urge for people to take a look at that. It's a key, it's part of the experiment, as you put it, Nora, which is, I think, very well put.
So just to jump in here, thinking about, we can vulnerable populations, getting them broadband access, getting them a high quality phone in their hand. We can think about that piece of addressing vulnerable populations, and it's really a question of health equity. But to take a step back in the bigger picture, I think that's I know on APA's radar is we're collecting all this healthcare data. We have lots of legacy healthcare data sets. How are those data being used by clinical decision support systems within hospitals? That becomes a question for health equity for vulnerable populations, because a lot of those epidemiological data sets are not representative of the healthcare population at large, especially within mental health. And if we're thinking about using those data to begin to make healthcare decisions for clinical decision support, developing algorithms using augmented intelligence to get people the right care at the right time for the right person. The legacy data sets that we have really shouldn't be used to, I shouldn't paint that broad of a brush, but it could be, I should say, it could be problematic to use those epidemiological data sets to create these algorithms that really leave out the vulnerable, especially within mental health. So, we could talk about, increasing access to live video and broadband and using all these apps. But when it comes down to it, once you put somebody into the healthcare system, how is the system and the new technology going to treat that patient?
Very good point.
Yeah, I hear that concern frequently. I think we're seeing that even with the COVID-19 vaccine rollout, that we can't reach certain populations maybe at the level we should, and that lack of reach exacerbates that data problem that you were just describing, because the data we do have might not be congruent to the problem that we're trying to solve. So once again, legacy systems, we got to watch them because they can trip us up, just like legacy CPT codes can trip us up. I have one more question for the panel before we transition to Q&A. Any thoughts on how this has impacted the workforce? For good or for bad? One of the things that I'm frequently accused of doing is you just want to replace physicians with computers and providers with computers. Like, well, no, that's not how that works. My spirit animal is the woman in the Geico commercial who's always saying, it's not how this works. That's not how any of this thing works. It doesn't magically create more doctors. It doesn't magically create more providers, but it does solve some problems in terms of access. And I wonder, now that we're through the whoosh kind of big transition, any thoughts on how we care better for our workforce as we move into this kind of technological era, what impact it might be having? What do you see?
Well, again, I think educating policymakers, the public, others, how this actually works. I was talking to one of my members, the whole discussion about payment and payment parity. Perhaps it doesn't cost exactly the same, but policymakers shouldn't think that physicians are at home in their pajamas, providing these services, that a lot goes into it. It is more efficient, but there needs to be a recognition of how much time is devoted to this by the practitioners. So I think on one hand, we've expanded access, but there still obviously is a great need for that physician, nurse practitioner, whoever the healthcare worker is, being engaged. And, there are costs associated with that.
One thing in terms of psychiatry that I know we're hearing from our members, when the EHR was first introduced into, practices, it seemed like no one thought it was going to be a panacea, but it created a different workflow, right? And we know that workflow has contributed to using EHRs and lots of rigorous documenting. It does contribute to physician burnout, and physician burnout is very real, and it's a problem with psychiatrists, just as it is for other providers. So as we think about how technology can be used to increase access to care, we also want to be sure that technology is not going to create any sort of financial or administrative burden on the provider, especially since there are too few psychiatrists practicing across the United States. We don't want to contribute we don't want any adoption of new technology to contribute to physician burnout.
That's what you said, Nathan, was the two things that really crossed my mind was that when people raise the "you're taking our jobs" sort of quip in response to us advocating for the rising role of technology in healthcare, it's widely demonstrated and acknowledged a physician shortage, and burnout is a huge problem, and I do know that even with that in some cases, you all may have talked to some clinicians before, and particularly physicians, which makes me the saddest that when I hear this is if I have to go through one more click, and some of that comes down to bad user interface and bad user experience. And I think that as developers of technology need to, from the earliest stage, you hear by design, privacy by design, and a little eye rolling, but it really is needed here is that a good experience for the clinician is something that has to be, it's essential, and there's a business necessity for it as well, if someone wants to think of it that way, for new tools and interfaces to actually be intuitive and user-friendly for the clinicians who need to rely on them. My physician, for example, I can tell you the last time I went to an in-person doctor appointment, my physician had hired somebody to just do all of the interfacing with the EHR system, to walk around on a cart while they actually did their job, And I think that's something of maybe that's a unique example there, but it is an issue. Another one too I'd raise is, this gets back to kind of like another legacy barrier that I've heard recently about from some physicians at a very prominent academic medical center, is that another restriction, even on live voice video, is that the distance site can't necessarily be in the home of the patient. You have to get an NPI number, register that site. There's hoops you have to go through in order to provide that care from a remote location too. And so I think that there's from the perspective of not just the beneficiary or the patient, but also from the caregiver, I think that looking at modernizing our regulatory constructs to better enable the clinician is in that lens is also important.
Couldn't agree with you more. I can't tell you how many new technologies fail because they're dropped on top of old workflow. It is a real, genuine problem. On our timeline, we are now finished with sort of the prepared component. And I have one question for each of our panelists. We're going to start with Nathan. Nathan, can you tell us a little bit more about what prompted APA to do the App Advisor, and how do you see that type of tool evolving as the digital landscape evolves?
Sure. So for those of you who aren't familiar, APA has developed App Advisor, which is, first of all, it's a couple of things, a couple of resources around App Advisor. It's a 5-step model that helps people to ask the right questions when thinking about whether an app is right for them, or if you're a clinician, if you want to use a certain app with a patient. It was developed, the first iteration of that was developed in 2016, and it came out of the work of Dr. John Torres out of a lab at Harvard. And then APA took it and ran with it, and we developed App Advisor, and we have an expert panel who are constantly tweaking the model, and they're working on a few other projects right now. That App Advisor panel is pretty unique in that it's not just APA member psychiatrists. We have clinical psychologists, social worker, a nurse practitioner, informaticists, and patients with lived experience who all come together to work on App Advisor. What prompted us to build this out is because, working in APA's policy division, I get lots of questions to our helpline. And a lot of psychiatrists really want, tell me what the best app is. What can I use to help treat depression? Tell me what EHR to use. And AP doesn't make any endorsements. So this is a tool to get people to work out for them whether or not an app is appropriate for use. In the future, I see this evolving. We're working on a project right now where we're taking the app model, which tells you how to evaluate an app. Well, now we're going to create resources to actually figure out how to use mHealth in clinical care. It's not a clinical guideline, but we are developing a best practices guide as an extension of that model for actually using mHealth. So if you haven't seen it yet, check it out, psychiatry.org/AppAdvisor.
That is super cool and badly needed, I think, as the head of a trade association that isn't allowed to have opinions about things. People are desperate for that kind of guidance, Nathan, so I think that's great. Next question for Brian, and I love this question because I do a lot of work in the interoperability world. Brian, do you think this push for true integration of technological advancements will actually drive us to true interoperability, or at least a better version of it than we currently have?
Yeah, it's a great question. I think I would say yes is my short answer. I realize that this is not, realizing true interoperability is, I don't know when that will happen. But I know that, I think that it's a widely understood issue that as far back as 2015, when Congress passed a law enabling a part of the Health and Human Services Department to define illegal information blocking and then go and enforce against illegal information blocking. That's what the info blocking rules, I guess, really are. I think we'll play a role here. From my own perspective, it does seem that I think I would generally agree that maybe before that rule, we seem to have something of a problem, and that, the use case that I think was in Congress's mind were probably the most egregious ones, where hospital A needed a record from hospital B, and they were on different systems, and someone wanted 25 grand to make an electronic file transfer and stuff like that. And it seems that those days are over, fortunately. So we're moving away from that, but hopefully the information blocking rule will push us in the right direction. And we do have a standardized technological spec for interoperability here that should continue to evolve and needs to continue to evolve. I think in my just humble estimate, I think that the info blocking rules will help in this respect. So that's my part of my yes. But also I think that we're at a place now where we have a level of interoperability enabled by the standardized spec. What data is actually useful? Because bombarding a clinician with a bunch of data that they don't need and making them sift through it will make them frustrated and doesn't necessarily help. That might be the next level. And how do we address that problem? That's a very interesting question to me that I think you'll find tons of different answers on and experiences about. But certainly I think we're moving there. It's tough to say when we'll attain true interoperability, but it is a great question, very thought-provoking.
Absolutely. I do think the information blocking rule is still underappreciated, the anti-information, for what it's going to do to the ecosystem, making sharing the default. So we've got some time, I think, for that to play out. Last question to Mary. Mary, have your members shared concerns with you about how we make sure in the future patients are not left behind by all this change? It's a big, broad question. but it's important.
Well, I'm delighted to say that my members are fully committed to getting us to a truly patient-centered, value-based healthcare system where they are rewarded. The incentives are lined up to reward getting better patient outcomes. And I mean, many of my health systems members view their job as, what can I do to keep patients out of my hospital? How can I better manage their care? So if we can line up those incentives and make it work so that we have collaboration among all the different sectors. So you have the providers of healthcare, but you also have the pharmaceutical manufacturers, medical device manufacturers. And instead of being viewed as an additive cost, that they're now part of the solution. So what is the appropriate regimen of medication to make sure that that patient stays healthy or that you prevent the development of chronic disease? How can a medical device manufacturer provide more efficient care? We talked about remote patient monitoring, an important tool. So I think all of those incentives lining up the right way. And we have seen as part of this pandemic, those that were in a value-based healthcare system, those that had a large portion of Medicare Advantage patients did financially well. They didn't suffer as much as those volume-based fee-for-service providers. So I think in some ways the pandemic has reinforced the need and hopefully has accelerated us towards that position and getting to that system. And it's one that is very, very consumer and patient focused and will result in better outcomes and lower costs. So that is the holy grail that I think we're all looking towards, and then certainly having all those tools that have been discussed here today, like interoperability, appropriate apps, the appropriate regulatory and legislative scheme to make those things happen. So I'm very optimistic about how patients and consumers will be treated going forward. I think we've learned a lot of real world lessons as part of this pandemic.
I completely agree with you. In closing, what I'll say is I always feel like Americans sort of are the epitome of the Winston Churchill quote. We always do the right thing after we've tried everything else. So there's been a lot of trying everything else. And then with the pandemic, I think it has forced alignment of some of these things that were only happening in pockets or only happening over here and only happening over there, only in academic settings or only this or only. There's no only anymore. It is now a big open green space for development of things that will move us towards the future. And so I want to thank Mary, Nathan, and Brian. I could listen to these three people talk all day. Incredible information, very optimistic, I think tempered with the realism that this stuff is hard. This is not a policy space for the faint of heart. You have to really have some stick with it to itness, and you have to really care about patient outcomes. And I think if we're doing the right thing, driving towards patients, then all of the rest of this will sort of fall in line the way that we need to. And so with that, I believe it is my job to throw it back to Deborah Barrett and thank the Otsuka team and everyone who went and did the work to put this panel together. It's been outstanding. I've enjoyed being a part of it, and thank you all very much.
Thank you.
Thank you, Nora, and thank you. We had the easy job, which was putting the panel together, and to Nathan and Mary and Brian and yourself, that was a fantastic conversation, which hopefully will lead to to many more. Thanks to everyone for their participation. So that concludes our first panel discussion. We're now going to take another quick break before our next session begins. As a reminder, in order to watch our next session, which is on mental health crisis response, another really important topic, please go back to the main dashboard of this event and click the session on your agenda. Within the session page, again, there's a join session button, which will appear about 5 minutes before the session begins, and we look forward to seeing you then. Thanks. Welcome to our second panel discussion on mental health crisis response. As we start our session, I'm honored that Otsuka's very own representative, Congressman Jamie Raskin of Maryland's 8th District, where our Rockville office is located, agreed to introduce this discussion with a video. Representative Raskin has been a champion for the Maryland mental health community and the drive to improve the state's crisis response system and the availability of providers and services. His real-time experience as a legislator seeking to ensure access to mental health care services, just as that need exploded during the pandemic, is a reminder of the urgency of this work. Thanks to his efforts, the Congressional COVID Relief Package included vital funding for community behavioral health clinics, pediatric access programs, and support for frontline workers. We look forward to continuing to work with Congressman Raskin to ensure the necessary attention and resources continue as we confront the challenges of mental health care. Let's listen to his comments.
Good afternoon, everyone. It's Congressman Jamie Raskin from Maryland's beautiful 8th Congressional District. I want to thank all my friends at Otsuka for your leadership and for hosting this great discussion today. You have shown a wonderful commitment to changing people's attitudes about mental health illness and reducing the stigma and the fear that too often accompany these deadly diseases. And I want to especially thank you for hanging tough through the pandemic period. Before the pandemic, about 1 in 5 adults reported experiencing mental illness. That's more than 50 million each year. But the COVID-19 crisis has been ruthless and terrible for our people. And as many as 40 or 45% of Americans are now reporting symptoms of anxiety and depression. And this has put an enormous strain on our population and also on the public health and mental health infrastructure. Look, we've put in remarkable resources in the American Rescue Plan to try to get people the help that they need. We finally got the government back on the side of the people. $3 billion in block grants for preventing and treating substance use disorders and for community mental health clinics and services. Another $420 million for certified community behavioral health clinics. $280 million for programs that support mental and behavioral health and will prevent burnout among healthcare providers and public safety officers, which of course is a huge problem during this time when everybody is being stressed to the max. And we got $80 million specifically, I'm proud to say, for the pediatric mental health care access program. And this has been a very successful model that's helped a lot of families and children living with behavioral health conditions get the treatment that they need. We are facing persistent workforce shortages, as you know, in the field. 70% of the counties in America do not report having even a single child psychiatrist. And only 1 in 5 kids living with anxiety or depression is actually receiving treatment. So there's a big treatment gap there, especially in rural and underserved urban communities. And many states have responded by integrating mental health services into a primary care setting. 21 states, including Maryland, have established a dedicated telehealth or telephone consultation hotline that's staffed by psychiatrists, psychologists, social workers. This gives doctors the ability to have rapid clinical psychiatric consultations, to do education and referrals for patients when necessary. So the telehealth has been a really critical element in responding to this crisis. The pediatric mental health care access program has significantly increased the number of kids that are able to get mental health treatment. And I'm happy to say that we've provided $80 million in the American Rescue Plan to expand this program from about half the states to all 50 states and DC and the territories. So I'm urging my colleagues to maintain robust funding for the program to support existing grants to the 21 states that are currently doing telehealth consultation, and also to allow for an expansion to all 50 states. I was very proud, and Sarah was very proud, and our whole family moved by the decision of the Maryland General Assembly to add to the 24-hour crisis helpline that Maryland has on the 211 number. Also, a new program named after our late beloved son, Tommy Raskin, which allows people to sign up to be called by a counselor periodically for a check-in. And that's a wonderful step and a big step forward for Maryland to do that. So look, I know you've got wonderful speakers here today. Robert Gebbia, the CEO of American Foundation for Suicide Prevention, Andy Keller, the president and CEO of Meadows Mental Health Policy Institute, Angela Kimball, the National Director of Advocacy and Public Policy for NAMI, the National Alliance on Mental Illness, and Kimberly Williams, the president and CEO of Vibrant Emotional Health. I hope everybody has a great conference, that everybody comes back with new ideas on how we can get everybody the mental health care and attention that they need and deserve. Thank you for doing all the work that you're doing to promote wellness in our community, and thank you for having me.
A great call to action from the Congressman. We appreciate his leadership and remember and honor the memory of his late son, Tommy, by recommitting to address mental health care workforce shortages and to building an enhanced crisis response system. Now we're ready to begin our second panel discussion. The Congressman did my job for me in terms of introductions for Robert Gebbia, Andy Keller, and Kimberly Williams. I'm going to gladly turn this over to our very able moderator, Angela Kimball, National Director of Advocacy and Public Policy at NAMI, and really look forward to the discussion.
Thank you so much, Deborah. I'm going to turn now to Robert Gebbia of AFSP. Representative Raskin just highlighted a number of federal actions, but I'd love to have you highlight some of the national policies that you believe are showing that our country is prioritizing mental health and suicide prevention.
Well, thanks, Angela. You know, we see a real change happening, and it started before COVID, but certainly since the pandemic, I think we see that accelerating. And that's one thing about that, is that we see the public discussion of mental health just escalating in ways it had not before. We see it in media attention. We see it talking in our families, in our communities. And we see it among members of Congress and in state legislatures like we haven't seen before. And certainly, as the Congressman mentioned, some of the legislation in the American Rescue Plan certainly addressed mental health. Telemental health has been on the rise and available in ways it wasn't before. But we think one of the most important actions taken by the federal government was the approval of the National Hotline Designation Act late last year, and that made 988 the new call number for mental health crises, suicidal crises, and ties that into the National Suicide Prevention Lifeline. Now, that doesn't take effect, and it won't be available nationwide until July of 2022. But now we're in the planning stage, and I think that's really critical that we get this right, and that as that rolls out, we also rethink and reimagine what crisis response looks like, and that we invest in the capacity to really answer the increased demand that we are expecting for crisis support. So I think we have a real opportunity here. I think it comes out of COVID, it comes out of the increased discussion about mental health, and in a growing need, certainly, as we know, incidences of depression, anxiety, substance use, and other conditions, mental health conditions that put people at risk for suicide, on the rise. We need to be ready to meet that demand. And so we're excited about these changes, but there's a lot of work to do to make them happen.
Thank you for that, Robert. And I'm just going to follow up briefly. I mean, you talked basically about how COVID-19 has increased mental health and suicidal ideation. You talked about the importance of the 988 bill. Can you explain a little bit more about what kind of role you think that's going to play in responding to all these increased needs that our country is seeing for mental health and suicide prevention?
Well, I think as we're more open about our mental health, more people will be reaching out, and they need to. When we see an increase in contacts to whether it's the Lifeline or it's the crisis text line, that's a positive because the problems are there. And now we see more people reaching out for help and getting them connected to help. The congressman referenced this, but, about half the people who have a mental health condition are not in treatment. And so how do we make that linkage? How do we get them into care? And in a way, the crisis response that we have, that really is the first step towards getting care for many. It really is part of our healthcare system. I think for too long, crisis has been over here and the healthcare system's over here. It really is a connected part of the healthcare system. We need to start thinking about it that way. And that's going to take some policy change in terms of how do you pay for it and in terms of third-party payers and so on. But I do believe that seeing crisis response as a part of healthcare, as a part of the continuation and continuity of care, I think is what we have to push for now.
Oh, thank you so much, Robert. Now that we have 988 in law as a 3-digit number that'll be available across the country by July of 2022, I think what you were saying is we need to ensure that calling 988 results in a mental health response to mental health crises. And I think this is really important because millions of mental health crisis calls are made every year across the country. And when an in-person response is needed, I have to say law enforcement is the typical response now. And that's not only traumatizing for people, it's also often tragic. Since 2015, nearly 1 in 4 fatal police shootings have been people with mental illness, with 1 in 3 being people of color. And frankly, we believe this is inequitable and it's unacceptable. And that's why advocates, and I count AFSP, NAMI, all of our organizations here, Vibrant, have been working across the country to pass state laws that establish, and you mentioned this, Robert, the need to fund 988 crisis systems. And the vision we're championing includes 3 core components that provide help when and where people need it: 24/7 crisis call centers, mobile crisis teams, and crisis stabilization programs. And Kimberly has amazing expertise in call centers, so I won't talk about those here. But the goal is for call centers to be able to help the vast majority of people in crisis. But some people in crisis will need an in-person response with mobile crisis teams that travel to where a person is to de-escalate, to assess needs, and connect people to care. And when a person has more acute needs, crisis stabilization services provide a safe therapeutic setting that reduces ED visits, and it can reduce the need for hospitalization. And this reimagining of crisis response, as you put it, Robert, is such a huge shift. And it's particularly important as we experience seeing rising rates of mental health challenges during this long pandemic. And so now I want to turn to Andy to talk more at the state and local level. I'd like to ask you how organizations like the Meadows Mental Health Policy Institute are engaging federal, state, local governments to address this escalating mental health crisis. We can't hear you. Andy, can you hear me? Okay, I can't hear you. All right, it looks like we have a little challenge with Andy's microphone right now. So I might just head over to Kimberly, if that makes sense, till we figure things out. All right. So Kimberly, you've heard Robert and myself talk a bit about 988 crisis systems, and I want to say there's an enormous amount of planning that's needed to set up and coordinate a 988 crisis response system in every state. And by the way, going live in July 2022, how has Vibrant Emotional Health engaged in this planning?
Thank you, Angela, for raising this question. And you are right that there is a lot of planning that is happening in order to prepare for this transformative change that is going to happen. So Vibrant has been very focused on ensuring that states are prepared for this transition. And so what we have done earlier this year is to make an investment in states to support their efforts around implementation. We actually awarded 49 states and U.S. territories with 988 state planning grants. And these grants essentially are enabling states to develop strategic plans for the projected infrastructure needs, volume growth, as well as access to the new 988 number. States are also using the funding to develop a roadmap, right, for how they're going to address coordination, capacity, funding, as well as communication strategies that are really foundational to the launch of 988 in July of 2022. As part of the planning process, Vibrant is working with the Educational Development Center, the EDC, and other national partners to provide technical assistance to states. A key part of the planning effort is stakeholder engagement. So states are required to create and convene a 988 stakeholder coalition group with representation from a broad group of stakeholders. So this planning is well underway, and we are looking forward to states presenting their initial plans this coming August, with final plans due at the end of the calendar year.
Thanks, Kimberly. You know, that's an enormous amount of work. I was wondering if you might be able to help our audience understand a little bit more about the Lifeline itself and its network of call centers, because I think there's a lot of confusion about that and the role it plays in the 988 crisis system.
So the National Suicide Prevention Lifeline, through a network of 180 independently operated, independently crisis call centers, provides round-the-clock free and confidential emotional support to people in suicidal crisis or emotional distress across the United States. And the role that the Lifeline plays in supporting this national network of crisis centers includes routing calls through the network to the nearest local crisis center or national backup center, setting clinical standards and sector-wide best practices, and providing constant quality assurance, training, assessments, and guidelines to ensure quality, effective help for people in crisis, running state-of-the-art technology to ensure responsiveness, including online 24/7 chat platform technologies. We also provide specialty national services for the network, such as the national backup centers, the Lifeline's crisis chat centers, and Lifeline's Spanish-speaking subnetwork, as well as translation services and accessibility options for individuals who are deaf or hard of hearing. We also partner with the National Association of State Mental Health Program Directors so that we can work closely with state officials to promote awareness and approaches for successfully funding local Lifeline crisis centers. And we provide grants to temporarily support some states to answer more Lifeline calls until they can sustain their own funding, along with the state planning grants that I noted earlier.
Thank you so much for that, Kimberly, and for sharing the work that Vibrant's doing to advance crisis care across this country. It's really pretty remarkable, and I think people don't know how much goes on behind the scenes to make this possible. So I'll turn back to Andy now and see if the microphone situation is resolved. Andy, do we have
Can you hear me?
Oh, we do. That's wonderful.
You love technology when it works. It's so good. Well, actually, I think it was that someone in fact made this happen, because it's much better to go after Kimberly, because Kimberly described so well what that national infrastructure is, and then the planning processes that states are undergoing. And that's essential. And, I just want to really folks recognize that the 911 system we have today did not get implemented in 1 year. I mean, it started and things happened. So having that front end and those phone supports and the connections and the statewide plans are so important. But just to give you context here for Texas, so our statewide grant that we got from the federal government is a $188,000 grant, which we're very thankful for. But we have 30 million people. And so we have to figure out how to get all of that. And the state's doing a great job. The grant's good. It's doing what it's supposed to do. But there's also hundreds of municipalities and organizations that have to get their call centers aligned, 39 mental health center jurisdictions that have to get their centers aligned. And so we also have to make sure that something happens after the call, that someone comes and the right person comes. And then, Angela, you described that whole continuum. So just to give you an example, communities fortunately are stepping up and doing that. And also a lot of the funds that are coming from the federal government through COVID relief and COVID response are flexible enough, particularly those under the American Recovery Plan, to start building some infrastructure. So we're trying to help cities and communities do that planning now. And I think Robert's point was so important about how this is really mainstreaming and making mental health care healthcare, as opposed to a public safety response. And that's what happens, Angela, in that world that you described, that when we rely on police, who, by the way, don't want to do this either, we are basically having a default public safety response, no matter how well trained those police are, no matter how specialized the crisis intervention training is, still fundamentally a public safety response. So integrating that into our health systems is really important. So we have call centers. Some of the neat things that are happening, for example, in San Antonio, the same group that coordinates trauma response to an auto accident and figures out, okay, where does an ambulance go if there's a multi-car accident and 30 people are injured? How do we get them to the different trauma centers? That's the same group that's coordinating sort of 988 development in that community. But there's a couple other things we need to do in addition to just 988. 988 has to be integrated into 911. We can't just do the crises. We have to make sure that there's a response when there are emergencies. And when someone, and unfortunately, many of those cases, Angela, that you described that involve deaths of people with mental illness when law enforcement comes, are people who are either suspected of having weapons or had weapons, regardless of whether they were actually posing a threat. Having a knife, a cahoots team can't go deal with that. So you've got to be able to have an organization that does not just relegate those folks to police and say, okay, well, if you have a knife, then the police come. We have to figure out how health professionals can be integrated there. The other piece is we have to integrate it more broadly with our emergency response. We have about I'm going to pick one Texas community, I won't name it, but it's pretty typical. It's a large community, and they have 6 mobile crisis teams, and they're looking at maybe doubling that to 12. They have over 80 ambulances on call at any point. The response time for the mobile crisis teams is they're happy if they get there within 30 minutes. They're feeling really proud of that. Response time for fire and rescue is 4 minutes. So we have to be able to take that to that next step, which we're not going to do in the next couple of years, but we have to be thinking about that. And I think that's really essential to getting to be able to even further into that integration, because if we think about heart disease, for example, we didn't start out putting people on low cholesterol diets. We started out trying to get to the scene and resuscitate people. And that's why crisis response is so important. But getting ahead of these illnesses, like Congressman Raskin was talking about through child psychiatry access programs and all these others, that's got to be part of this too. But we really need to deal with the kind of, we're not going to be taken credibly for anything as a healthcare sector if we're still having the primary people who respond to our most acute needs being law enforcement instead of health professionals.
Thank you, as always, for your incredible insights, Andy. That was wonderful. I think, given that we have a little extra time, I really want to go back to this notion of call centers, mobile crisis teams, and crisis stabilization services. And I think a lot of times for people, they're a little bit abstract. So I thought I'd just share a little bit about a personal situation for me a few years ago when my son was experiencing a psychotic episode. So I was able to call a behavioral health crisis line, and with 988, it'd be much easier to remember and dial, because I can tell you that in situations like that, it can be very scary, and it's hard to remember even simple things. And since my son was delusional, he was threatening at times, this was not a situation that could be resolved over the phone. And that crisis line dispatched a mobile crisis team. And Andy, to your point, in this case, the mobile crisis team was actually a co-responder model, meaning it had behavioral health professionals along with well-trained CIT law enforcement officers. But the behavioral health professionals took the lead. And they were non-threatening, and the law enforcement officers were also non-threatening. They listened to my son. They listened to me separately. They looked around at what all had been happening, put together the pieces. And the behavioral health therapist said, I'm hearing, Alex, that you haven't slept for days and things are getting kind of intense. I bet you'd really like to have a good night's sleep. Is that right? And he said, yeah, my head hurts and I just want to be able to sleep and I can't. And she said, the doctor at the hospital will definitely be able to help you get to sleep and help your head stop hurting if you're willing to go with me. Does that sound okay? And kind of remarkably, he said, yes, I just want my head to stop hurting. And she was focused on what he was feeling and needing, not on clinical terms like paranoia and delusional, or a psychotic. And she didn't talk about psychiatric hospitalization. She talked about, sounds like you need a good night's sleep and your head needs to not hurt. And the next step in his journey was a crisis stabilization unit, which after 23 hours, and this is in a kind of living room-like environment, open, different people, mental health professionals, he was moved into psychiatric inpatient unit because he was still delusional and paranoid. And while I can't say the rest of the journey, the hospitalization went well, the crisis response piece did. And this is what we want across the country, because under different circumstances, my son could very easily have ended up in jail or worse, shot and killed because of his behaviors. So I really appreciate what you had said, Andy, about how this is affecting our country and individuals everywhere. And I want to throw out another question to all of you, and that's that, we've seen some traumatizing stories of young children dying by suicide, handcuffed and even shot in response to a crisis. Yet most people think of adults when they think about crisis care. So I'm interested, for all three of you, what do you think we need to be doing or thinking about when we're talking about crisis care and children?
Yeah, I would say, this is really important because we're seeing higher rates of, mental health conditions among our young people. And we are encouraging them to reach out, right? We have all kinds of educational campaigns going on in schools and colleges. And, we have a program that we do with the JED Foundation and the Ad Council called Seize the Awkward, which is encouraging a friend of someone who they see them struggling to talk with them about it and encourage them to get help. So all of this outreach is going on, but what happens when they reach out? And I think we have to be really prepared. There's not enough child psychiatrists. There's not enough people trained in working with young people. We know there's a workforce shortage there. We need to do something about that. But I also think in crisis response, to train people on how to address young people who reach out and come in contact with the system who are in crisis. And we need to also educate families about this too, what to do. And I think there's so much that needs to be done to improve the outcomes for our young people. I just want to go back to one thing too you mentioned. I thank you for sharing your personal story, because it really is, it's the model we need to work towards for everybody and make that available everywhere throughout our country. And I do think there's some new funding opportunities to do that if states and the federal government step it up in terms of their investments. And I do think it can save lives. It can improve the outcomes. The 988 legislation, right, also allows states to have fees on phone bills. And I know it's controversial, but you know what? That's a funding source for crisis services, that would be enormous at the state level. And it's similar to what happens with 911. And we need to advocate that states do pass legislation to make that happen so they can fund these kind of services locally. And that's something we need to work towards. Our advocates are pushing that in state advocacy days in all 50 states. And there are a couple of states that got out in front on it and others who are hesitant. We need to raise the bar on that and make sure they're doing that, because I do think it can make a big difference, as well as the federal government. It has a responsibility here as well. But I do think young people are an important part of this. We cannot forget them in this picture.
If I could just add, I'm so glad you asked this question, and Robert's points are so well taken. I think one thing we need to do is help people make a shift in their thinking, because I think people don't realize that half of mental illnesses begin before age 14 and another quarter begin before the brain is done developing in your mid-20s. These are pediatric illnesses. And part of why we think of them as adult illnesses is that's when people get treatment. So on average, we wait 8 to 10 years after symptoms emerge before we treat, which is also a big reason why people don't get treatment until they're in crisis. And we have to look at crisis as a point of linkage. So one thing we need to do is change. And so the programs that Congressman Raskin talked about that are these child psychiatry access programs are really important, because it changes the dialogue that goes on in pediatrician offices early on, so that we help parents and caregivers, grandparents, whoever's with that child, begin to frame the child's behavior in terms of emotional development and wellness, and it's a developmental issue and something that is a health issue. So if we begin then, we begin to change the dialogue. We also have to change systems differently, because the systems that serve children are different. So we have to have a school-facing component. And one thing we've done in Texas is we've put together a telehealth network specifically for schools for urgent care. So when a teacher or a principal is worried because I'm drawing pictures of guns, and so they're wondering why I'm doing that, they can help me and my parents get access in real time to a telehealth visit with one of our child psychiatry programs in the state. We have all 12 of our medical schools linked in. We have almost 2 million of our 5 million students in Texas have access to this, and other students have access to other programs. But this one is a nice one, because a lot of times, and particularly for students of color, when there's a behavioral issue, it is law enforcement that comes. And we've done some good job reforming those laws in Texas and other states where we no longer allow that call, but we got to give schools something. Otherwise, the child's going to get home and police are still going to get called. So, and I think we also have to remember that while we're rebuilding systems, rebuilding our juvenile justice system is just as important. There is no system in America that has more children that have suffered trauma and more children struggling, often with not very complex mental illnesses like anxiety and depression, or PTSD, which is more complex, that are treatable, but we're labeling these behaviors as behavioral problems, and then putting the child in a restrictive justice type setting as opposed to a health setting. So we have to just make several repositionings, and also remember that those systems are different for children.
Thank you. That's fascinating, Andy. Kimberly, anything to add?
The one thing that I would agree, with both what Bob and Andy said, the one thing, just to kind of further the point around what Andy was noting, is the need for coordination across systems, and recognizing that kids are in many different systems: mental health, healthcare, schools, other child serving systems, juvenile justice. And so there's a real need to make sure that leaders and providers across those systems are actually coming together, including also families, young people, and working collaboratively to really understand what the needs are on the ground, and to effectively coordinate services delivery and make sure that there are the actual resources that are needed to provide effective care and treatment.
Absolutely. Couldn't be said any better. Thank you, Kimberly. And, after all this talk about kind of crisis care, some of you were talking in a sense about intervening early. And so I really want to ask how we can ensure that our mental health system isn't focused solely on crisis care. For example, what kind of tools and resources do individuals and caregivers need to prevent crisis, as well as to recover from them? Any thoughts on that?
Well, I'm happy to jump in on that one. So I have 2 illnesses that I struggle with. One is anxiety, and one is heart disease. That's in my family. So I didn't get treatment for my anxiety till, 20 years after it started, in my mid-20s. I got treatment for my heart disease 20 years before I had any clinical manifestations because my primary care doctor screened for heart disease, screened for cholesterol. And I think we have to get universal detection, and we have to do it in pediatric settings. We have to detect these illnesses before they become crises. That's the only way we've ever gotten ahead of anything. I mean, look at cancer detection. If we can detect it at stage 1, and our good friend Paul Gianfredo and the folks at MHA really, I think had an important campaign about before stage 4. Well, it's not just that, we got to get stage 1 and maybe even pre-stage 1. So I think that's the mindset, and every step you can get before crisis to get someone linked into care, whether it's an urgent care or ideally this detection and universally in primary care systems, is what we need to have.
Thanks, Andy. Robert, any thoughts on that? Oops, we can't hear you.
There we go. There's good evidence. I think Andy's spot on. I think there's good evidence to show early intervention has better outcomes. And, if we wait so long after the onset of symptoms of mental health conditions to get a diagnosis, to get the proper treatment, the outcomes aren't as good. And I do think early detection and intervention, and also, again, education of families, understanding, we all want to do the right thing for our kids, but often we don't recognize when we see these problems what they are, and don't seek professional evaluation and help. And so I think there's a component about public education or mental health literacy, early detection, better training of our clinical workforce. And most young people are going to be seeing a pediatrician or a primary care doctor. They're not going to see a mental health provider. And how do we train them better to be a part of this detection and the linkage then to the kind of mental health care that might be needed? So there's lots of pieces. We also think there's a big part about educating the peers, and especially among young people, because often the parents and the family don't see it. They don't know what's going on, but the friends do. And can they be a force for raising the conversation and getting someone then to seek help, a young person to seek help and talk to a trusted adult? So I think there's a lot we can do there as well.
Fascinating. And I think that goes back to what Andy was saying about, mental health conditions disproportionately occur earlier in life. And yet that often those are ages when people aren't listening to adults in their life, they're listening to their peers, as you're saying, Robert. So how do we use the best methods to reach people where they're at so that they can engage in care, get help, feel supported? Kimberly, I guess I've always thought of the Suicide Lifeline as being for adults, but I haven't posed the question. Do you get calls from children or youth?
Of course we do. Yeah, we do. We do get calls from young people, both young people reaching out via call and also via chat. Yes, we have a variety of people with differing needs who are reaching out for help. And I actually wanted to touch on one point related to your question, Angela, because you asked about before crises, but you also asked about what to do immediately after a crisis. And I think, there needs to be more focused attention on seamless and continued connection to care that's based on the appropriate level of need of the individual and the way that they want to access care and the most comfortable way that they want to continue to access care. And a big piece of this is follow-up to ensure that individuals are supported and get and stay connected to treatment. Studies have shown that a reduction in the number of deaths by suicide, when follow-up is actually provided for high-risk populations. Studies also show that brief, low-cost interventions and supportive ongoing contact is a really important piece to, keeping people safe. So I think that's just another component of the continuum that we need to be sure that we're investing in.
Can I just add on what Kimberly's saying, because that's such an important point. And I think a lot of times people do need hospitals. Sometimes hospitals, crisis centers, super important. But what we found is a lot of our diversion is as much from the hospital as it is from the jail. And because most people really don't. Most people really that we have found and in the communities we're moving forward with these crisis reengineerings, they really need a same day or next day medical appointment. So same day if it's during the day, or next morning, to see a physician or a nurse practitioner, somebody who can really address and get them back into their treatment and those linkages. And that's been, we've seen a really just as big of a diversion from hospital emergency rooms as we have from justice settings. And I think that's both important. It's primarily important for people's lives and the efficacy, but it's also really important from a cost containment to be able to fund these services, because we're going to save a lot more by keeping people out of emergency rooms and hospitals than we are out of jails. And I think so that lower level contact, I think a lot of times, we're in a rush to think about, okay, the most acute cases, absolutely we need crisis care and we need more. We don't have enough of that. But we also need to have these same day urgent access and linkages to ongoing supports, often home housing supports, other co-occurring addiction supports. So that's such an important point, Kimberly. Thank you for making that.
And if I could add one other thing, I think as we talk about, especially cost, Andy, as you bring that up, there's still such a problem getting affordable care and getting access to affordable care. And I think now is the moment, as we look at crisis response, we also need to look at mental health parity and say, why hasn't, after all these years, that been implemented across the country as it was envisioned? And we need to advocate to make sure that that implementation of mental health parity happens, because even when people want to find care and need care and recognize the need, finding a provider that takes insurance, these are all real barriers, and waiting lists, and to get on a waiting list for a provider. So I think mental health parity also has to be part of what we think about when we think about crisis response and envisioning the whole mental health system. There needs to be that parity.
That's another thing about the administration I'm excited about, Robert, is the new Secretary of the Department of Labor is someone who has lived experience and who's made this a priority, the enforcement of parity laws for businesses and others that provide insurance. I theoretically have insurance, but I think we all find that when we have these needs, it takes us like a dozen people before we find somebody who's either alive or in our network. So that sort of enforcement is coming, and I think it's going to be super helpful.
I'm glad you all touched on access, and Kimberly, the need to follow up. Like, people need care after a crisis. And I'll just go back to my son's experience. After he was discharged, or as he was being discharged from the hospital, the psychiatrist who was working with him there suggested that he might really benefit from a long-acting injectable form of his medication, because he would go off and things would go awry, and that would start a cycle of crises that are potentially avoidable. And the hospital staff sat around this table and said, "Oh, that won't be covered. We can't do that." So they handed him a slip of paper with, prescriptions and an appointment that he never followed up on, and, ended back up in the hospital within a week. And so you think about the small things that can be done, yet we have a system that puts up these barriers to people getting the care they need at the right time, when it's actually very expensive to do things the way we're doing and experiencing as much failure as we're experiencing. So glad you all touched on that, and I couldn't agree more in terms of parity. We need a shift in how coverage occurs in this country, and that it's really fair and equitable. And I think even just talking about crisis in general, we're uncovering a bias in the system. We would never expect law enforcement to come in response to a physical health crisis, and yet we routinely expect that with a behavioral health crisis. And the fact that that's occurring is just inexplicable, and it's long overdue for a change. With that, I think I'll move to a question that we have from the audience, which is, all behavioral health care is local. What work is being done with counties and cities to stand up new crisis response systems?
Well, I could talk about a couple we're working with. One thing is the work is being done, it's locally generated. And that's kind of risky, right? Where we're hoping that the local communities will have this prioritized along with all the other things they're struggling with, alongside homelessness, alongside reopening post-COVID, for those communities who feel post-COVID. And so one thing that's wonderful is the American Rescue Plan dollars. So I'll just take one community, one of our larger communities in Texas. You know, I mentioned that $200,000 planning grant for 988 that our whole state has. This community is going to get $700 million under the American Rescue Plan to use for COVID response. And they're not alone. This is what every community is getting on a prorated basis. Every city above 50,000 people is getting a direct payment. Every county is getting a direct payment. So what I would say is go back home and make sure your local community leaders have this on their agenda, because they have an unprecedented amount of money that, I mean, never in my lifetime has this amount of money been available to respond to needs. So one of the allowable post-COVID needs is mental health and addiction. So the communities we're working in, and many communities that we're not working in across Texas, we hear are prioritizing this planning locally and using these funds to start building up some of the infrastructure. There's also, I know many of us are going to be asking the administration in the infrastructure bill, if it goes through, to include infrastructure supports for local communities to build up that system that we're talking about. So, but in the meantime, go to your local communities and generate that local conversation, because there's too many communities and it needs to happen too quickly to wait on some central authority to come out and do that. So that would be my encouragement on that. And I think we have unprecedented access to resources over the next couple of years to do that.
I think that's an important point, and they're time limited. So I think communities really need to take advantage of the opportunities that are in front of them right here, right now, because those dollars will not be there forever. Another question that we've been posed is, what's the best way for states to provide effective accountability and oversight for these crisis services? Any thoughts on that?
I mean, I think it speaks to the larger question about collecting data, you know, and making sure that, you know, as we do change, that the data supports that the things we're doing are working, that they're effective. And I do think there's an obligation in anything that we do to measure it, to measure the impact and to collect the kind of data that shows it's good or bad, or working or not working, and how then can we correct it. And I think for so many years we've done things because they seemed right, but not collecting the kind of data to support that. And I think this is an opportunity to use data. There's so much more, I think, emphasis on that than ever before, as there should be, evidence behind things. So I think that's the accountability, to collect data and to share that data, have transparency on that, and to make changes that things that aren't working and to correct them. So I'd be a strong proponent of data collection here.
Wonderful.
If I could put a plug in for one particular data point, Angela. You know, the national response to the mental health and substance use needs from COVID that has been brought together, that you all serve on, a lot of us serve on, I prioritized 6 action steps, one of which was data. And one of the things they mentioned there that they highlighted was that we don't know how many people are dying from suicide until a year later. So I could tell you in excruciatingly detail how many people died from COVID in every Texas city in the last month. And it's more reliable if I go back 2 weeks. I'm going to have to wait till 2022 before I know how many people died from suicide. And there's maybe some more care that needs to be done there. But I mean, I think we put too much care. That needs to get out. Those data need to be out, just like any other public health data, much sooner than a year later.
Wonderful point. Kimberly.
Yeah, I was just going to add, just on the data point, just that, you know, for instance, the centers that are part of the Lifeline are required to collect and report on data. Everything from call volume to average speed to answer to percentage of caller disposition categories, gender, age, number of callers who identify, you know, as veterans, percentage of calls that require emergency dispatch. There are sort of a number of key components that they're required to collect and report on, and how just informative that is in terms of really understanding who is reaching out, what the need is, and can therefore inform further planning.
This is fascinating. There's so much that can be done with data, and I will say that also takes investment. And I think one of the challenges we've had is that crisis systems, including the Lifeline, have really been shortchanged in terms of funding, and that's something we have to invest in. You can't improve without having the infrastructure to be able to examine what are you doing and what are the outcomes of it. And I'm going to switch.
And also, I would add to just
invest
in the training that gives you better outcomes, right? The quality of the care and what happens in crisis is important. And I do think the Lifeline's doing a great job. I think there are so many more services in the crisis world that aren't getting that training, that are outside the Lifeline system. And I do think we need to invest in the training, especially of the staff and volunteers it's going to take to bring on board to meet what is projected to be a major increase in demand and call volume as 988 goes live. So I think we should really emphasize training as well.
That makes a lot of sense. And there's a question here from the audience about how do we influence policies so that those who want to help youth in crisis can do so outside of hospitals with access to appropriate interventions when needed? Wondering if anybody wants to take
I'm happy to. So I think some of the things we talked about earlier are really appropriate there. You have to have a place for children to go. And as Kimberly was saying, there's a different system of coordination we need to have. And I think it needs to center on schools and primary care. Primary care really is where we're going to find early. And also it's much more accessible if we have the supports in primary care. There's a lot of studies that show, particularly for youth of color, as well as marginalized communities in terms of poverty, which often intersects. If someone has to come back for a second appointment, there's sometimes cultural reasons, like in Asian Pacific communities. There's a sense of where it's much more socially acceptable to get the care at the family doctor than it is to go to another doctor. So there's cultural reasons sometimes in many communities, but there's also just the practicalities of how do I take off work a second time to get my child somewhere? How do I arrange childcare for my other kids to get this child in? So if it's integrated at the pediatric office, it's much easier to have those kinds of follow-ups. And then doing the linkages through schools, like we talked about, ideally through telehealth. If we're not leveraging telehealth, then we're losing a huge opportunity.
Well, let's talk about telehealth a little bit. Kim, Robert, does that play a role in crisis services or in the entire spectrum of mental health services?
Absolutely. I think it's key in terms of providing people with access to care. And it sort of goes back to the point earlier that we want to be able to reach people in an easy way that is effective and that reaches them in the places that they're most comfortable. And telehealth is the way to go. A lot of people are quite comfortable accessing care electronically. And so the expansion of that, the continued availability of it, ensuring that's of high quality, making sure that that's integrated within the crisis system is, I think, going to be really key moving forward.
Yeah, I would agree. And I think the other thing we realize is that there are the availability of mental health care is not even across the country. And you look at rural communities in particular, and the lack of a mental health provider, psychiatrist, and telehealth opens up the possibility we can better serve rural communities and the needs, their mental health needs, by having access to telehealth. And that also applies to communities of color and other places where there aren't really the providers. And I think this really is something that needs to be expanded and used, going forward. And I think to Kim's point, so far it seems like the quality is there. I guess that's got to be looked at more and studied more, but it doesn't seem like there's a lack of quality when you deliver care that way. Just the way we're doing this program, right? We're all virtual. We're not in the room. It's working as if we're all sitting together. I think the same thing applies to telehealth, telemental health.
Well, and amazingly, I mean, mental health is one of the most prominent services used by telehealth, at least in the last year. So that shows that to me, that there was a great unmet need. And as you point out, Robert, the willingness to use that technology to access care. And if that doesn't continue, there are a lot of implications across this country where there's a dearth of providers in so many counties all across the country. And actually, there's an interesting question that popped up. If you had a magic wand, what's the one policy change that you think would quickly and effectively improve patients' lives? Not sure if there's just one policy change, but I'll toss that out there.
Funding. Yeah. This really comes down to funding. I mean, there has to be adequate investment in mental health resources so that we can actually build greater access and capacity.
I appreciate that, Kim. What we pay for reflects what we value. Mm-hmm. And our country has systematically not paid for mental health and substance use care, suicide prevention at nearly the same levels as other health care. So that's an incredibly important point. Andy, Robert?
It brings to mind something related to, and that is, the mobilization of political will, because I think certainly when I got involved in this work, I was told, well, there's no political will here. Mental health just doesn't get, and suicide prevention in particular, just doesn't have the mobilization of the public behind it, and therefore it doesn't change and doesn't get what it needs. I think that's really shifted, but we need to keep working towards that and build the kind of voices like you're doing, Angela, in your own story, and people telling their story, those who've lost loved ones to suicide because of the lack of access to care. These are the stories, and people with lived experience who are speaking out about how they struggle with suicide and how they got help, and how that informs others who are in that position. I think all of these voices become really critical if we're going to get the change we want. So it's not one policy, it's many, but I do think having the political will to make it happen and really reinforcing that with our legislators, both state and federal and local, I think will make a difference.
Well, and since I can't ask for 10 more wishes, and I can only do one, I would like people to believe that their brain is a part of their body. That is what I would like. And so for people to quit saying mental health versus physical health, if they would just say mental health versus other physical health, if they would, and I think if we actually believed, if more people, I think the four of us believe that the brain is part of our body, but if more people did, then people would be outraged at hearing that somebody had police come when there was a mental illness, as opposed to just, I actually had a mental health clinician, a very senior mental health clinician a month ago, explained to me that they thought that the best way to re-engineer crisis response was to train every social worker as a police officer, because then they'd be able to handle these things. And I'm like, no. It's so embedded, this sort of belief that we have to do something different with mental illness, and we can't just treat it like an illness. So that would be my wish.
Well, given that wish, Andy, and the fact that you were testifying before a congressional hearing last month, what are you seeing in terms of changing attitudes amongst policymakers in DC? Anything that's giving you hope? Well,
yes. First of all, one thing we learned from COVID is that mental health and addiction is real. Everyone experienced it. Everyone, especially if they had home delivery of alcohol. People experienced it last year. And you could feel it in the legislators' questions. These were personal questions now, which often is. A lot of people in Congress have personal stories and come, but it was much more universal. I'll tell you, I am sure that telehealth is going to keep around. And I love that they talked about audio only, which I think, by the way, meetings like this have helped convince us all that audio only is nice. Don't you love it when it's not a video call and you can just talk without having to look at your face? So audio only, and there's a lot of research that works. I think the thing that I was hopeful about too is that I like to see that the health committees are talking more about this, because I don't think yet 988 is in the mainstream of the health committees. It's more in the mental health piece, and it has to be in that health discussion, and that's the part that I think is our challenge. It's being talked about in the justice community, It's being talked about in equity discussions, but we have to get it more of a mainstream health discussion. And that's the other takeaway I had.
Wonderful. Well, thank you all, Robert, Kimberly, Andy. This has been a fascinating discussion. I so appreciate everything you added to this conversation. It was wonderful. And with that, I'd love to turn it back over to Deborah.
Thanks so much, Angela, and thank you again to Robert and Kimberly and Andy, the four of you. That was a really interesting discussion, and we appreciate your thoughtfulness and your participation today. We are reminded, and it goes without saying, but how critical it is that we have a strong crisis response system. I would just note in another piece of good news, we were pleased to see that the latest COVID relief package included about $1 billion over 10 years to states, specifically for mobile crisis units. So when we talk about more funding, we're getting there. For everyone watching, that concludes our second panel discussion. Please join us for our next section, which is the Better Together Awards ceremony. We will take another quick break prior to the ceremony. In order to watch the ceremony as you have done before, please go back to the main dashboard of this event, click the ceremony in your agenda, and within that session page, hit the join session button, which will appear about 5 minutes before the session begins. And we look forward to seeing you there. Thanks. Thanks, everyone. Welcome, everyone, to our Better Together Awards ceremony. Today, we are honoring 3 leaders, 2 of whom are with us in person and 1 by video. They are receiving this award in recognition of their commitment and leadership to supporting access to mental health care and the needs of those living with mental illness, especially at a time when the pandemic has underscored that those needs are growing exponentially. These policymakers have shown true dedication and commitment to the mental health community and are more than deserving of this recognition. Up first, we honor one of Otsuka's own representatives, longtime friends, and fellow mental health advocates, Congresswoman Bonnie Watson Coleman of New Jersey's 12th District. Second, we have on air with me here a key Senate leader on healthcare, Senator Bill Cassidy of Louisiana, and Lori Chris, the director of the Ohio Department of Mental Health and Addiction Services, who is here representing her boss, Governor Mike DeWine, and their collective efforts on behalf of Ohioans with mental health care needs. Our first recipient is Congresswoman Bonnie Watson Coleman, who, as I mentioned, we're so fortunate to have represent the Otsuka U.S. headquarters in Princeton, New Jersey. We want to honor the Congresswoman for her ongoing commitment to creating a healthier future for our country's youth, prioritizing the need to destigmatize mental health, particularly in minority communities, and for reintroducing the Pursuing Equity in Mental Health Act, which is a real step forward in fighting racial disparities in mental health access. Otsuka is proud to work with Congressman Watson Coleman, and we want to offer our congratulations and thanks for her leadership.
Thank you, Deborah, and thank you to Otsuka for this award. When I first came to Washington, the issues of mental health awareness and advocacy were not at the forefront of my mind. But over the last few years, as I've come to recognize the urgency of this problem, in no small part due to the advocacy of the people watching this event, it has become a passion of mine. 2 years ago, I established with many of my Black Caucus colleagues the Emergency Task Force on Black Youth Suicide and Mental Health. It was created in response to the immense pain that I was seeing from families that had lost children. The suicide rate among Black children, especially young Black children, had been rising. Our task was to find out why and what could be done. The task force convened a working group, and 9 months of research and hearings in Washington, D.C. and around the country, we produced a study and the Pursuing Equity in Mental Health Act. It'll provide resources to improve access to mental health care in underserved communities, to tackle the stigma surrounding mental health, and to train the next generation of mental health professionals with the cultural competency needed to save some of our most vulnerable children. It is up for a vote on the floor of the House later this week, and not a moment too soon. The COVID crisis has been eye-opening. It has exposed many shortcomings in how we treat people, especially treating their mental health. It's also exacerbated many of the challenges we were already facing. We may be vaccinating our population and rebuilding our economy, but we cannot ignore the mental health needs of people who witnessed loved ones dying, those who were trapped in difficult and dangerous family situations, and frontline medical personnel who are suffering from burnout and have been displaying the symptoms of PTSD. It will be a long road back for our country, and I'm ready to get to work, and I'm glad to know that you all are in this fight as well. Thank you again.
Thank you, Congresswoman, for your commitment and leadership, and again for the time today. Next, I'm pleased to welcome, as I mentioned, Senator and physician Bill Cassidy. We are recognizing the senator for his dedication to improving the mental health of our veterans and underscoring the need to ensure equal access to mental and physical health care. His introduction of the Mental Health Parity Compliance Act of 2019, Improving Mental Health Care for Veterans Act of 2020, and the VA Research Approval Efficiency Act of 2020 are all critical steps to help improve the lives of those living with mental illness and improve the health outcomes within our healthcare system. Additionally, as a physician and a leader on the Senate Health Committee, the senator has worked tirelessly to promote policies that connect mental and physical health, a fundamental step to ensuring integrated and available services. Senator, we're so pleased to have you here today. Thank you for your leadership and congratulations on this award.
Thank you, Deborah, and thank you for the award. I am honored. I prefer to look at even tragedy as an opportunity. We know that COVID has worsened mental health outcomes, but I would like to think that it increases the awareness of what we need to do to address mental health issues and to put momentum behind them. First, Deborah mentioned I'm a doctor. I think she did. And so as a doctor who treated patients with liver disease, oftentimes who had suffered from addiction or had mental health issues, I became aware of the lack of integration of psychiatric and mental health services. So Deborah mentioned that's one of our emphasis, but that's something that Chris Murphy and I worked on in the 2016 mental health reform bill that got signed into law as part of 21st Century Cures. And we're hoping that that integration can more easily occur. There's other things to do, though. For example, we know that during the pandemic, that anxiety, depressive disorders increased from 1 out of 10 adults to 4 out of 10 adults. It took a particular toll upon healthcare workers. So one piece of legislation that I'm pushing, that I have bipartisan support on with Tim Kaine from Virginia, is the Dr. Lorna Breen Healthcare Provider Protection Act. She is the doctor who committed suicide just from the stress of all her work with COVID. This expands mental health resources to the nurses, the physicians, and others caring for patients. It's also intuitive that those with serious mental illness would be particularly vulnerable during the pandemic for worse clinical outcomes. And so we must be aware of that. Now, sometimes that manifests itself by somebody doing some activity in which they end up being arrested. There is something called the Medicaid Inmate Exclusion Plan, which is to say that when someone is arrested, but before they've been adjudicated, they lose their Medicaid benefits. So imagine somebody is on that antipsychotic regimen that's really working for them. Maybe they've done something to allow them to get, that causes them to get arrested, but they're otherwise functioning in society. They're holding a job, etc. They enter into the jail. They're not adjudicated, but they lose their Medicaid benefit. Whatever they're given is that which is on formulary, which oftentimes is not that which has controlled them. We are going to introduce a bill, working on it now, so that the mental health provisions of Medicaid would follow someone into jail before they are adjudicated. Now, one thing that is leading to attention, again, looking for silver linings in all the tragedy, the increase in homelessness, many of whom are addicted or seriously mental ill, has increased support for such a bill that would allow these mental health services to continue as long as somebody has not yet been convicted. So that is one piece of legislation we're working on. A couple of other things that we're working on: telehealth, which I think telemental health has shown to be quite valuable. Dual eligibles, a third of whom have been diagnosed with serious mental illness. These are those who are on both Medicaid, Medicare. Terrible outcomes, even though we spend a lot of money on them. And then parity enforcement, working with Senator Murphy to bring to realization our previous legislative efforts to establish parity between emotional health and physical health. I'm pleased to say that both the Health and Finance Committees are holding hearings upon the COVID mental health issue overall, as well as health disparities. I welcome your feedback. This has been a partnership. Whatever we have achieved so far, it has been us working together. So I look forward to continuing this work together. So much depends upon it. And our past success shows that we can have future success as well. Once more, thank you for the recognition. Deborah, I turn back to you.
Thank you, Senator. And again, thank you for your leadership. There's, as you've pointed out, so many different pieces of legislation you're working on that we would like to work with you and support your efforts moving forward. Finally, we'd like to welcome Lori Chris, who's the Director of the Department of Mental Health and Addiction Services in the state of Ohio, who will accept this award on behalf of her boss, Governor Mike DeWine. On the front lines in the state of Ohio, Lori is leading and executing on the priorities of Governor DeWine to improve access to mental health and addiction services for Ohioans in need. Governor DeWine's creation of the Recovery Ohio Advisory Council and his 2020 expansion of telehealth options, allowing people access to treatment from the safety of their homes, are two recent examples of his leadership. Lori herself has been a leader in the behavioral health field since 1992 and is particularly immersed in how Ohio's communities respond to mental health and addiction for people of varying cultural and racial backgrounds. Lori, we are honored to recognize Governor DeWine with this award and applaud your efforts and commitment. We look forward to our continued collaboration in improving access to mental health care.
Thank you, Deborah. It is a pleasure to join you today, and I'm honored to accept this award on behalf of Ohio Governor Mike DeWine. I would like to thank Otsuka America Pharmaceutical for their commitment to helping Americans who are living with serious mental illness find treatment and support. As you said, Governor's DeWine's first official action as governor of our state was to create the Recovery Ohio initiative to coordinate and improve mental health and substance use prevention, treatment, and recovery support services in Ohio. He is steadfast in his commitment to give those struggling with mental illness a system that provides quality treatment on demand. And he prioritizes building recovery-friendly communities that support and promote health and wellness to ensure all Ohioans can access services and live long, productive lives. From the onset of COVID-19 and the pandemic, Governor DeWine recognized the fear, isolation, and loss that would result, and he quickly mobilized state resources to ensure that the behavioral health field remained open to Ohioans. I am proud to say that thanks to his foresight and quick action, Ohio was a leader in the nation in our response to the pandemic. As part of this work, he moved quickly to expand telehealth, which created opportunities for access and choice, critical elements for treatment and recovery. And when our state psychiatric hospitals had to reduce capacity due to COVID protocol, we entered into partnerships with private psychiatric hospitals to ensure continued care for Ohioans who need it most. We also worked quickly to offer vaccinations when they became available to both our hospital staff and patients in order to prevent the spread of COVID among this vulnerable population. And we launched Ohio's Careline, a toll-free number that connects Ohioans to trained, licensed clinicians who answer calls 24/7 to provide emotional support and brief interventions and make referrals to local treatment providers and community agencies. And just as importantly, Governor DeWine talks about mental health regularly with Ohioans. His understanding, compassion, and public acknowledgement of what Ohioans are experiencing have helped us make great strides in reducing stigma around mental health, letting people know that it's okay not to be okay and that it's okay to ask for help. All of his efforts have included a strong equity lens to ensure that each Ohioan has access to care and resources, no matter their age, ethnicity, gender, socioeconomic status, or geographic location. As everyone here has experienced, it has been an unprecedented year with incredible challenges and losses. And despite these challenges, we also have an incredible opportunity to leverage the innovation, creativity, and lessons learned during a time of crisis to deliver even better care for Ohioans living with mental illness and their families. We appreciate the efforts of Otsuka Pharmaceuticals to bring together leaders and experts in the mental health field and to explore solutions to increase access to care. Again, thank you so much for this honor for Ohio Governor Mike DeWine. We join you in congratulating Senator Cassidy and Representative Watson Coleman as well. Thank you.
Thank you, Lori. And again, thank you for your efforts, for the governor's efforts. We appreciate really all of your work and collaboration. And that concludes our Better Together award ceremony. It was really great to see the faces of some of our recipients, and we would look forward to supporting their future efforts to strengthen access to and the quality of mental health care. We will now take our final break. Our last session will begin shortly and include remarks from Governor Tom Wolf of Pennsylvania and Otsuka's own Allison Rosenthal. Again, one last time, to watch the closing remarks session, please go back to the main dashboard of this event, click the session in your agenda. Within that page, a Join Session button will appear 5 minutes before the session begins. Thank you, and we look forward to seeing you soon. Welcome to our last session of the day. We have been honored by all of the leaders and advocates who have joined us today, at least virtually. Virtually joined us, I should say. Before we conclude today's event, I'd like to introduce my friend and colleague, Allison Rosenthal, the VP for CNS Sales and Marketing at Otsuka. Allison is the Otsuka leader with her passion and commitment to patients and her interest in joining arms with this policymaking community to make progress on our shared goals of broader access, better understanding, and improved outcomes. And I just want to say a personal thank you to this community for joining us today and participating as you have in these discussions. A lot of work to do, but a lot of commitment. It's very exciting, and I walk away even more inspired. So Allison, over to you.
My name is Allison Rosenthal, and I am the Vice President, Neuroscience Business at Otsuka Pharmaceutical. In my role, I am privileged to lead a team of dedicated professionals who care deeply about helping people living with mental health challenges. I feel privileged to be part of the team developing programs at every stage in the life cycle of products, from ensuring the successful introduction of new indications and research for our existing products, to preparing the market for new compounds in our mental health pipeline, to finding new opportunities for our products to improve patient care. It's my pleasure to give the closing remarks to what has been an excellent and poignant discussion of the challenges we face in advancing mental health care in the United States. I also want to thank our expert panel members who did a tremendous job identifying blind spots as well as opportunities to impact legislation and introduce solutions and services that will benefit people living with mental illness in the United States. As Governor Wolf mentioned, and others have recognized, Otsuka understands and respects the value of every mind. Our legacy in mental health and commitment to developing solutions for mental illness and neuroscience has persevered despite a large industry exodus from this area for many years. Otsuka is committed to using its unparalleled knowledge and understanding of mental health to address patients' unmet medical needs by developing innovative treatments. We are one of the only pharmaceutical companies that continues to invest in developing pharmaceuticals, pills and long-acting injectables, digital medicine, and digital therapeutics for the treatment of mental illness. It is our belief that effective treatment may extend beyond the pill, and other options are needed to augment the physician's toolbox, especially in diseases such as serious mental illness. The impact of the coronavirus pandemic has only reinforced the need for and benefit of integrating digital tools into behavioral health care, and we're encouraged by the future opportunities for digital innovation in mental health care and patient support. That is why we've made a significant investment over the last decade in digital health solutions to empower patients to take control, understand, and manage their disease in partnership with their physicians. We acknowledge that we're only at the beginning of this journey. However, advancements in digital health will, over the long term, improve patients' experience with the healthcare system and one day allow for an enhanced understanding of diseases, leading to better treatments. We have a vision to meet customers where they are through their preferred medium, delivering resources and messaging that are personalized to their needs. This will allow us to design a bold, efficient, customer-centric engagement model that can adapt to evolving market needs and is tailored to ecosystem players. Patient centricity ensures we deliver a valuable and additive solution that is easy for patients to adopt and integrate into their daily lives. We're at an inflection point in the US where diversity and inclusion are finally becoming pillars of long overdue focus. Otsuka has been collaborating with companies such as Verily to virtualize clinical trials and drive greater patient centricity, as well as greater diversity and inclusion of trial participants. Earlier this year, Otsuka and Click Therapeutics announced the initiation of the Mirai study, which means future in Japanese. It's a first of its kind, fully remote clinical trial using digital therapeutics as adjunct therapy in adults with major depressive disorder. Now, more than ever, there is a need for a scalable digital solution that can dramatically expand access to mental health treatment without sacrificing the rigors of clinical validation or a patient-centered focus on engagement and user experience. These important innovations are bridging the care management gap between patient and healthcare professional by enabling remote and virtual monitoring of disease factors and data, ensuring critical information is available for care consistency, thus providing and even strengthening the patient and healthcare professional therapeutic alliance. I'll conclude today's session by stating a fact. Only by working together can we inspire and achieve continued innovation across the industry to address the behavioral health needs of patients and more broadly across the entire healthcare delivery chain. I encourage all of you to stay involved and take action locally in your communities to build on the great work already being done. There are several ways to do this. First, someone you know could be struggling with mental illness and simply may not know where to find help. Simply knowing a good resource can help save a life. We've learned several resources are available and on the horizon, such as the nationwide Mental Health Crisis and Suicide Prevention 988 number. And as discussed during today's sessions, while it is a major step in saving lives, there is much more work to be done. Secondly, reach out to those policymakers at the local, state, and nation level who make decisions on funding, coverage, and access to treatment and services. Encourage them to drive change by standing up for those living with mental illness. They can do this by passing bills to improve access and remove barriers, reduce stigma, and support initiatives that provides access to care in a timely and affordable manner. And finally, contact the local affiliates of a mental health advocacy organization, such as Mental Health America or National Alliance on Mental Illness. They may have many volunteer opportunities that you could get involved in or sponsor local mental health awareness events such as walks or runs. In closing, I want to thank all of the participants for your invaluable contributions to today's sessions and for helping to shape the future of mental health. And thank you to everyone who attended today's discussion. I hope you found today's event as informative and inspiring as I have. We are truly better together, and I look forward to working with all of you to advance mental health care in the United States. Thank you.